cannot answer, no need to worry at all. Be at ease, and that's what I want to say. And more discussion will follow. So, without taking much, it will ask Reena to present the case, and we'll have. Yeah.
Yes, sir. Good morning, sir. Good morning, everyone.
Yeah,
Today
Reena,
my
you can. Yeah. Yeah.
today my case is on pregnancy-induced hypertension. 22-year-old primary gravida, housewife by occupation, resident of Mumbai, came for routine ANC checkup. On examination, her blood pressure was 160 by 90 mm of Hg, and patient also complained of headache, which was present since 1 day. History of present illness. Patient is a primary gravida with 36 weeks of gestation. Came for routine ANC checkup, and on examination, her blood pressure was found to be 160 by 90 mm of Hg. Headache was there since 1 day, progressive and bilateral, pulsating, aggravated on physical activity, and not relieved on any medication. But there is no history of any blurring of vision or syncopal attack. No history of any reduced output or chest pain. No history of chest pain, palpitation, breathlessness on exertion, or history suggestive of any cardiac failure. There is no history of epigastric pain, nausea, vomiting. No history of jaundice or ascites before 20 weeks of gestation. No history of any diabetes mellitus or hypertension previously. Obstetric history. Patient is married since 2 years, non-consanguineous marriage. Gravida 1, para 0, L0. LMP is the 3rd of November 2022, and expected date of delivery is 10th of August 2023. Present pregnancy, first trimester, patient had morning sickness for 2 months. There was increased frequency of micturition, no history of easy fatigability, and there was no history of discharge of any bleeding PV, no history of any drug intake or radiation exposure in first trimester. Second trimester, quickening was there as fifth month. There is no history of headache, blood vision, or sudden increase in weight. Patient was following continued antenatal visits with 2 TT injections taken. An anomaly scan was done at 28th week, which was normal. Third trimester, fetal movements were present. There was no history of any bleeding or discharge PV, no history of pain in abdomen. Menstrual history, age of menarche is 15 years. Menstrual cycles of 30 days, 4 days of flow, no pain or passage of clots. Last menstrual period was on 3rd November 2022. And there is no history of any contraceptive usage. Family history, no history of diabetes mellitus, hypertension, asthma, or twinning in family. No history of PIH in mother or any sister. Any on maternal side, there is no history of PIH. Past history, no history suggestive of diabetes, hypertension, asthma, epilepsy, tuberculosis. There is no history of any blood transfusion or previous surgical history. Personal history, diet, mixed, appetite is good, sleep is sound, bowel and bladder is regular, addictions are nil. Drug history, patient started taking tablet Folwite 10 mg daily in first trimester. Iron tablets and calcium tablets started in second trimester, continued till present day. Patient has been started on tablet labetalol 200 mg twice a day. I have seen patient after 2 days. Patient came to hospital 2 days before, so tablet was started that time. General physical examination. Patient is conscious, oriented to time, place, and person, lying comfortable in bed, moderately built and nourished. Height is 152 centimeter, weight is 65 kg with a BMI of 28 kg per meter square. Vitals, pulse is 90 beats per minute regular, normal volume, no radial or radiofemoral delay. Blood pressure, 150 by 90 mm of Hg in right arm in sitting position. Saturation on room air was 99%. Patient was afebrile, no pallor, icterus, cyanosis, clubbing, or any lymphadenopathy present. Patient had bilateral pedal edema, which was pitting. Breast enlarged. Spine examination reveals no significant abnormality, but edema is present on the back. Airway examination, mouth opening is more than 3 finger and basic grade 2. Thyromental distance is more than 6.5 centimeter. Neck circumference is 36 centimeter. Upper lip bite test 1. No loose or missing or artificial tooth. Neck movements are normal. Breath holding time was 24 seconds. And patient does not give any history of snoring. Abdominal examination, inspection, ovoid longitudinal uterus, trigravidum, linea nigra present. Umbilicus is central in position, no scar sinuses present. On palpation, symphysiofundal height is 36 weeks, non-tense, non-tender. Fundal grip, soft, broad, irregular mass that is felt suggestive of buttocks. Lateral grip on left side, smooth, regular, convex, hard structure felt suggestive of back. On right side, irregular knob-like structure felt suggestive of limbs. First pelvic grip, hard globular structure felt suggestive of head. Second pelvic grip, findings of first pelvic grip confirmed. Fingers of both hands are converging, suggestive of head is not engaged. On auscultation, fetal heart sound is 148 per minute, regular in rhythm. Systemic examination, cardiovascular system, S1, S2 is heard, apex beat in fifth, mid-clavicular line, no murmur. Pressure is comfortable with no breathlessness. Respiratory system, normal vesicular breath sound, air entry bilaterally equal and clear, no added sounds present. CNS, conscious, oriented to time, place, and person. All higher functions are normal, all reflexes are normal. So my provisional diagnosis is 22-year-old primary gravida with 36 weeks of gestation, single live fetus with cephalic presentation with head not engaged and not in labor, with pregnancy-induced hypertension for safe confinement.
Thank you, Rina, for the candid presentation of this case. I'd just like to ask you things pertaining to her history.
Yes, sir.
Why do you think Dr. Kalpana has chosen this case for today's discussion?
So pregnancy-induced hypertension is very common in our setup. Pregnant patient mostly they come with pregnancy-induced hypertension.
So you
So
mean to say that it is the commonest medical disorder complicating pregnancy, right?
yes, sir. And maternal mortality is means maternal mortality causing PIH. Means PIH causing maternal mortality is the means second most common.
So it is the commonest cause of maternal mortality, the
Yes, sir.
second most common cause of maternal mortality,
Yes,
right?
sir. Yeah.
So what is the rough incidence, approximate incidence of preeclampsia complicating pregnancy or hypertensive disorders complicating pregnancy?
Sorry, sir. Incidents, I don't know.
Anybody in the audience? Rough incidence among in the pregnant population, what is the approximate incidence of preeclampsia or hypertensive disorders complicating pregnancy? Well, Reena told us that it is the commonest medical disorder complicating pregnancy. Yes, she is very correct in that sense. So how common is that? Bhavya, Anish, I can read few names. You can unmute yourself and involve. See, basically, this is, as I said, it's just an informal or a formal discussion. Don't have to worry about anything. So roughly, as nobody's answering, it varies from about 8 to 11%.
Okay, sir.
So about 8 to 11% of all pregnant women can have this disorder complicating pregnancy. So you said the second most common cause of maternal mortality. You're right. So when you are doing PSC, would you like to do targeted PSC, more targeted PSC, so that, okay, this is the commonest cause of maternal mortality.
Yes, sir.
Amongst hypertensive disorders, what are all the conditions in this spectrum that leads to maternal mortality?
So intracranial hemorrhage is the commonest. So
Intracranial hemorrhage is the commonest. You're right.
yeah.
IC bleeds, intracranial events. Yes. Then
Sir, then liver dysfunction if patient is having
hepatic ruptures.
hepatic rupture. Yes, sir.
Yeah, absolutely. So that is the you're going into a complication of preeclampsia, that is HELP syndrome.
HELP syndrome, sir.
So with
And pulmonary edema patient can present.
ARDS, yeah. So when you're doing PSC, we need to look for any of these features. And other thing is eclampsia.
Yes,
Also
sir.
can cause maternal mortality. HELP syndrome, the morbidity mortality increases. Abruptio, the mortality increases. So when you're doing PSC, we need to look into all the complications that are likely to ensue in this parturient so that you can do a targeted PSC, right?
Yes, sir.
So when you said syncope and blurring of vision, what is
Yes,
it
sir.
that you're looking for?
So my patient is having headache.
Yeah,
But if patient presents with actually it is comes with a severe feature with blood pressure of 160/90 and headache.
yeah.
Patient is having uh, visual symptoms, then patient can be having retinal detachment or any means cerebral involvement is there, sir.
Yeah. So you're looking for cerebral involvement and retinal involvement, right? Yeah.
Yes, sir.
So you said 160/90. So how do you classify hypertensive disorders in pregnancy?
Yes, sir. Uh, so gestational hypertension, wherein patient presents with a systolic BP of 140 mm of Hg, diastolic of 90 mm of Hg with no proteinuria. Pregnancy-induced hypertension,
Two reading,
preeclampsia, wherein
two reading,
patient present.
two
Hello?
readings taken 6 hours apart,
Yes, sir.
or one reading of 160, 100, or 160, 110.
Yes, sir.
See, there's a either single reading of 160 or 110 or 140, 90, two readings taken 6 hours apart. Okay. Yeah.
Okay, sir.
After
Uh,
20 weeks of gestation, you read, right?
yeah.
Yeah.
So then, preeclampsia with pregnancy-induced hypertension with the systolic blood pressure of 140 mm of Hg, a diastolic of 90 mm of Hg, with after 20 weeks of gestation, with proteinuria, taken two readings 4 hours apart. This will be without severe features. And if patient is present with severe features, then systolic blood pressure of 160 mm of Hg, diastolic blood pressure of 110 mm of Hg, with it could be with proteinuria or without proteinuria, but severe features are such thrombocytopenia could be there, wherein the platelet count is less than 1 lakh. Then liver dysfunction, which leads to raised AST, ALT, normally double the time. Normally it is 35, could be more than 70. Then LDH will be more than 600. Patient will be having, then sir, serum creatinine more than 1.2. Patient having headache, retinal changes, and patient having pulmonary edema.
So this
Uh,
this case belongs to preeclampsia with severe features.
yes, sir.
Yeah.
Then,
So
sir,
yeah.
yeah.
Then
Sir, chronic hypertension, wherein patient is hypertensive before pregnancy, and patient is a known case of hypertension.
or even before 20 weeks of gestation, right?
Yes, sir.
Yeah.
Then chronic hypertension with preeclampsia, wherein patient is diagnosed with hypertension with at 20 weeks of gestation, but the hypertension is continued 12 weeks postpartum, sir.
So why do you yeah, next what are the next?
And eclampsia is there, wherein the patient presents with seizures, mostly tonic-clonic, with hypertension and other features.
And HELP syndrome
Yes, sir. And HELP syndrome, yes.
and hypertensive cardiomyopathy,
Okay, sir.
heart failure, okay,
Yeah.
and HELP AFLP complex, right?
Okay.
So basically, you want to put this patient in the basket of preeclampsia with severe features, right?
Yes, sir.
Yeah. So when you are putting this patient with preeclampsia with severe features, anything else you would like to extract from the history?
Yes, sir. I'll ask for whether patient was having any pain in the right hypochondria, or patient is having any visual disturbances, whether patient is having any patient is on examination, whether patient is irritable or sound conscious and oriented, then whether her urine output has been reduced, any breathlessness is there.
When I say targeted PSC, like let us say you're going to anesthetize this patient. Like see, obviously when anesthesiologist is involved, this patient either wants epidural for labor analgesia or for cesarean section, right?
Yes, sir. Yes,
Cesarean.
sir.
So in that case, any targeted PSC, like specifically you want to uh, risk stratify this patient under a very high risk for anesthesia or low risk for anesthesia. So would you like to clinically, what are the things that you look for when you're doing a clinical assessment?
Sir, high risk factors, if patient is having renal involvement, if patient is having any antiphospholipid antibody syndrome.
So secondary cause of preeclampsia, like
Yeah.
especially lupus, morbidly obese, hyperthyroid, any of those things you want to rule
Yeah.
out. Right? Yeah.
And mild are, sir, if patient is age is more than 35 years, if patient has a ART, artificial reproductive technique pregnancy.
So CKD patients, any of
Yeah.
those. So yeah. So those are anything when you said there is no history of snoring, what was going through your mind when you said that point? You that was a very good thing that you mentioned in your history, no history of snoring. So
Uh,
what was going through your mind when you said this point?
Yes, sir. Actually, in pregnancy, there is normal pregnancy also. Patients have there is edema of airway, pharyngolaryngeal edema, and plus there is enlargement of tongue. So it can cause obstruction due to which patient is can have snoring, and on lying down supine, patient is not comfortable. Patient will have breathlessness, while in left lateral position they are more comfortable. So airway related, if our patient is means when we go in to give anesthesia, if patient goes in for general anesthesia, so anticipated difficult airway is there, and plus patient is having snoring, so it is we have to keep our all difficult airway cart ready, sir.
So when you say snoring, anything, any specific disease entity that comes to your mind?
Sir, obstructive sleep apnea.
Obstructive sleep apnea, excellent. So what is the incidence of obstructive sleep apnea in pregnancy, in preeclampsia, complicating pregnancy?
It's around 40%, sir.
Almost preeclampsia with severe PIH is almost about 35 to 40%. Yes. So unless you probe specifically into history, you won't be able to extract this feature. So if the patient snoring a lot, has a stop bank score. Of course, stop bank scores are not very specific in pregnancy. They have not been studied,
Yes, sir.
but definitely that gives a clue. So again, for the quickly for the audience, can we just enumerate the stop bank criteria?
Yes, sir. So S is for snoring, uh, O is for obstruction, uh,
People tiredness.
T for transient apnea, sir.
Yeah, others also can join. Only Krishnan, you can help Reena.
And then,
T,
Anish, please answer this. The stop
Yes,
bank
T,
chart.
S for snoring, T for tiredness, O for any obstruction, P for blood pressure more than 140/90, B for body mass index, and N for neck circumference and gender, male gender.
then presence of hypertension.
Yeah. So basically, again, as I said, this was the stop bank was not studied in pregnancy, in preeclampsia, but in general, tiredness is there in most of the pregnant patients. So it is non-specific. Neck circumference is one thing which can be taken in snoring. So when it comes to snoring, extreme forms of snoring is associated with hoarseness of the voice also. So one of the specific thing that you need to take up in the clinical history is
hoarseness.
there any change in voice?
Okay, sir.
Because if the patient has snoring with change in voice, that means the recurrent laryngeal nerve is getting compressed, the supralaryngeal part, because of excessive edema. And this is going to be a nightmare if this patient comes for GA. So any hoarseness in voice, we have had a series of patients, and when we subject them to direct laryngoscopy from the by the ENT surgeon, the glottic opening is as small as 3 to 4 millimeters. So it is impossible to intubate a patient even with 5 millimeters endotracheal tube. So you need to, when you are taking up a history, change in voice should alert you.
Okay.
Excessive snoring should alert you. Okay.
Yes, sir.
Elevated JVP should alert you. So even when you are examining the patient, generally we always examine the pregnant patient in little propped up position, 45 degrees head up. So with
Yeah.
that 45 degrees head up, if you see distended jugulars, again that should alert you. That means, is there an element of myocardial dysfunction or hypertensive related cardiomyopathy? That has to be kept in mind. Anything else you would like to say before you take up this patient for surgery or anesthesia? Reflexes. Don't let the assessment of JVP, assessment of airway, which including this history of snoring and hoarseness, and of course, routine airway assessment. Importantly, deep tendon reflexes, because how many of you assess reflexes routinely during PAC? None of us. Let me be very frank, because we all have gone through that phase. But make it a point, because when they come to us, either they are receiving max self, and before anesthesia, we need to know whether magnesium sulfate toxicity is there or not. So assessment reflexes becomes mandatory as a part of PAC. And if you're contemplating to give magnesium sulfate therapy to this patient, again, I would like to assess baseline deep tendon reflexes. Again, there are two schools of thoughts. Many obstetricians feel that there is no need to check reflexes. You can give safely the loading dose even if the parturient has acute kidney injury or acute renal failure. That is good. But I must tell you that 5 to 7% of parturients have baseline hyporeflexia. Hypo. Obtended reflexes baseline. Okay. So if you give loading dose of magnesium sulfate therapy, and who knows that this patient belongs to baseline hyporeflexia, and subsequently you check reflexes are not elicitable, then you end up getting confused that is it because of magnesium sulfate or is it because of this thing. So always it is prudent on the part of clinician to check baseline deep tendon reflexes. Okay.
Yes, sir.
So targeted PAC is very important. Assessment of airway. Anything else you want to? Why are you so much bothered about? You have done a very fantastic airway assessment. Why do you think that you have done so? You said difficult airway. So what is the incidence of difficult airway in pregnancy? In non-pregnancy? Like in a non-pregnant surgical cohort. Anybody in the audience?
So non-pregnancy, 4 to 5%.
See, roughly it is 1 in 3,000 to 1 in 4,000
Okay, sir.
in non-pregnant surgical cohort. In pregnancy, it is roughly 1 in 400. Okay?
Yeah.
In preeclampsia, it is 1 in 50.
Okay.
The incidence of difficult airway. And if this patient has thrown a seizure, eclampsia, it is 1 in 10. Okay?
Yes, sir.
So the incidence of airway is almost 10% in eclamptics and about 5% in preeclampsia. And as you go, but in general, the incidence is quite high. So airway assessment is very, very important. So especially when you have excessive snoring, hoarseness, you need to be aware. So now this patient has come to you, 160/90, headache.
Yes, sir.
And fortunately, you are in a setup where you and the obstetric team work in close association. So how would you start managing this patient?
Sir, I have seen patient too.
Is not in failure, lucid, conscious, coherent, reflexes are normal, everything is else fine. And she has been on labetalol 200 milligrams BD, you said. That's what you said twice, right? So suppose if this patient comes to you and obstetrician asks for your opinion, would you like to add anything in the management?
Yes, sir. Sir, since already she started on labetalol 200 milligram BD oral tablets, I've seen the patient 2 days later where the blood pressure was 150/90 2 days later. I can increase the labetalol dose 200 milligram BD to QID. Maximum dose is 2,400 milligram we can give.
Anything
Sir,
else?
we can add magnesium sulfate, sir.
We can add or you have to add?
We have to add, sir, magnesium sulfate.
See, basically, when you have a pulsatile headache, 160/90, it is always mandatory to add magnesium sulfate therapy. So basically, prevention of eclampsia is of my very, very important nature. We don't have to treat eclampsia. We have to prevent eclampsia. Am I clear on that?
Yes, sir.
So when the patient is having symptoms, it is better to start prophylactic magnesium sulfate therapy. In this case, it is not prophylaxis. The patient already is symptomatic.
Yes, sir.
Okay.
Yes.
So yes, we need to always note other cause of headache also. But with 160/90, headache of one day, pulsatile nature, better to start magnesium sulfate therapy also in this case. Okay. So how do you start? Like suppose if this patient comes under your purview,
Yes, sir.
how do you start magnesium sulfate therapy?
So for starting the magnesium sulfate for the loading dose, we follow the Pritchard regime, wherein we give 4 gram IV and 5 gram IM in both the buttocks.
Even in
So,
breech candy, you follow Pritchard regime?
uh, sir, they give infusion here. 1 gram per hour for 24 hours at least. It is continued seeing the symptoms, then they increase or decrease the
How do you
rates.
give 4 grams?
Pardon, sir?
How do you give those 4 grams?
So 4 gram IV, 20% in 200 ml NS, it is given slowly.
How do you give that? Each ampule contains how much?
Each ampule contains 50, means 1 ampule is 2 ml. So 1 ampule contains 1 gram, 50%. Means 500 milligram per ml. So 1 gram, 1 ampule is 1 gram.
Yeah, you're right. So then you give 1 gram per hour infusion, right?
Yeah.
So how do you maintain that 1 gram per hour infusion? How do you give that?
Sir, in 50 cc syringe, we can make it as 0.5 grams per hour, and we can give at the rate of 2 ml per hour.
So that is what you're giving at breech candy?
Sir, till now I have not seen, means in my 2 years I have not seen on magnesium. I've been go for the pre-ops, but I have not seen anybody being started on magnesium sulfate. So
Anybody else in the audience? How do you give? Yeah, you're right, Rina. You can always either give us a syringe infusion. So what is the advantage of giving by syringe infusion? What is the disadvantage?
sir, infusion, it is given in titrated dose, and means it is not given fast, and we can monitor the magnesium toxicity. Serum magnesium level is.
Volume
Pardon, sir?
is less. Advantage is you're giving less volume.
Yeah.
And you are giving titrated regime, like precise 1 gram per hour infusion, no doubt about it, yes. But the major disadvantage is hyperosmolarity.
Yes, sir.
See, 50%, what is the osmolarity of magnesium sulfate? 50%. It is close to 1600 to 1800 milliosmoles.
Okay, sir.
Okay. So, osmolarity is very high. What does it mean?
Sir, more of water retention.
Thrombophlebitis. The incidence of thrombophlebitis is very high. So, if you're giving this high concentration, the incidence of thrombophlebitis is very high and patient will have pain at the site of infection. So, either you have to give in a central line or a big peripheral vein.
Yes, sir.
Okay. So, that is a flip side. Otherwise, if you want to give it as an infusion in a drip form, 1 gram per hour, how do you make it? See, basically, all this management is done by obstetrician, magnesium sulfate therapy. But when the patient comes to OT, when the patient comes to ICU, it is under the purview of the anesthesia team and the critical care team, right?
Yes, sir.
You are going to manage this patient. So you also need to know how to give, how to administer, and how to titrate this regime. So generally what we do is magnesium sulfate therapy is always given in either ringal lactate or normal saline. So 1 ml of normal saline or RL contains 500 ml. So you remove 50 ml NS and add 25 ampules of magnesium sulfate.
Okay.
So it becomes again 500 ml.
Yeah.
And then you give 20 ml per hour.
Okay.
So 20 ml per hour, you give about 1 gram per hour. You just calculate. Yeah. Okay. So it is very important that you can then you give 20 ml per hour as a volumetric via volumetric pump.
Yes.
Okay. But when you're giving this, we'll come to fluid management a little later, but that is one of the method of given. Pritchard regime, which you said, also is fine, nothing wrong. But 5 grams in alternate buttocks.
It's very painful, sir.
Very, very painful. And the serum level, the steady concentration in the plasma also are not maintained. But nevertheless, that has been a standard therapy in most of those semi-rural or semi-urban areas. But otherwise, always follow Zuspan regime. The regime that we mentioned is Zuspan regime.
Zuspan regime, sir.
Yeah, 1 gram per hour, 1 to 2 grams per hour. Okay.
Yeah.
So you have started magnesium sulfate therapy. You have started this thing. Suddenly, the obstetrician calls this patient is having BP of 200 by 110.
Yes, sir.
So what is it you are looking at?
Some means the requirement of the patient is more. We can increase the load. We can again give the loading dose of 4 to 6 grams, sir.
And blood pressure has gone up to 200 by 110.
Yes, sir. So then it's an emergency, and we need to optimize and start. Means we should think about taking the patient for emergency LSA.
Why do you want to take up for emergency LSCS? Blood pressure has gone up.
So
So
first we need to optimize it.
What does it imply? What does it imply? 200 systolic, diastole is 110. It was 160/90 earlier. Now you get a call from labor room that patient has gone, BP's headache is worsening and BP is this thing. Okay, we may have to terminate the pregnancy, that is different. But before that, how do you stabilize this patient?
So we can.
What is that you're dealing with now? What is this entity of 200 by 110? How do you call this? Hypertensive?
Sir, it is malignant.
Hypertensive crisis.
Hypertensive crisis.
So how do you define hypertensive crisis?
So hypertensive crisis, wherein the systolic, where the diastolic BP is more than 110 and mean arterial pressure is more than 125 mm of Hg.
Yeah. So is it hypertensive urgency or hypertensive emergency? When do you call hypertensive emergency?
Emergency, sir, when life of mother and fetus both are compromised and you have only 30 minutes.
See, the thing is, yeah, you have to be very clear. When the hypertension crisis or hypertensive crisis is associated with end organ damage, like pulmonary edema, seizures, retinal detachment, acute kidney injury, elevated liver enzymes, it is known as hypertensive emergency. And when there is a potential for damage has not occurred, but she may throw a fit, she may go into pulmonary edema, she may go into this, then it's urgency. Okay?
Okay, sir.
But medical management is more or less the same. So how do you medically manage this patient? Yes, the surgeon wants to decide for surgery, take up for surgery, that's a different. But would you like to take up this patient immediately for surgery?
No, sir.
Want to stabilize? So how do you stabilize the patient?
So we need to reduce the blood pressure. We can give.
So what are the targets? How do you reduce?
So we can start NTG at the rate of 0.25 0.5 microgram per minute. Or
anything else? Anybody else?
Sodium nitroprusside can be started, sir.
See, don't you want to, what are the things that you routinely use for managing hypertension?
So hydralazine is there.
A common thing, bolo bhaiya. Samira Khan has given, Samreen Khan has given something. Look at the chat box. She has given one name of the medication.
If you definitely we can search.
See, yeah, labetalol, intravenous labetalol therapy.
Yeah, sir.
IV labetalol, have you used IV labetalol?
Yes, sir.
Yes. So, NTG and SNP are the drugs that are reserved for ICU only. ICU management only. You can always give, but that is not the first drug of choice. The first drug of choice is
Labetalol.
Labetalol. Yes. So how do you give intravenous labetalol? So suppose, let us say this patient was with 160/90. She's been managing labor room. So would you like to shift this patient to high dependency unit?
Yes, sir.
Yeah. So whenever you have high blood pressure or any of this on magnesium sulfate therapy, the moment patient is on magnesium sulfate therapy or on intravenous medications, they have to be monitored in HDU
HDU.
or ICU only. Labor room is a HDU setup, that's fine. But you need to define, suppose if the labor room is, the staff is not geared up, then better to shift this patient to a HDU area where you have the facility to monitor as well as to conduct delivery. Okay?
Yes, sir.
Both the things have to happen. So how do you manage? So shifting this patient to HDU is important. Then how do you give labetalol therapy?
So labetalol, initially 20 milligram IV is given, and then we wait for 20 minutes to see the response, and we can increase it to 40 milligram then.
So
Again,
what, like whenever you are answering, Reena,
yes, sir.
or whenever you're managing this patient in real life, like see, when you're doing a running race or any of this competition, you have certain goals, right? You have aim and objective. Okay, I need to complete this race in 20 seconds, in 30 seconds, in 40 seconds. So you need to define the goals.
Yes.
So you have a patient with 200 by 120 or 200 by 110. What are your goals? And what is the time frame you are looking at?
Sir, we need to reduce the blood pressure goals.
Goals of management of blood pressure. So I want to reduce the blood pressure, but not more than
Not suddenly, not more.
acutely. So what is that sudden? How do you define that sudden interval? And why is it important? Anybody? Anybody in the audience, please?
So sudden decrease in blood pressure from higher level to lower levels can cause sudden decrease in perfusion and organ damages and also.
Absolutely. Why?
So we have
You're right.
the perfusion decreases.
See, if you see, central nervous system has auto-regulation.
Yes, sir.
Renal kidneys have auto-regulation, right? Yes.
Yeah.
So what do you mean by auto-regulation? Even there is a transient momentary fluctuation in BP, the renal blood flow or cerebral blood flow remains constant because of auto-regulatory mechanism, right? Does the uteroplacental circulation has auto-regulation? No. Uteroplacental circulation do not have auto-regulation. Okay. So the perfusion of placenta, the perfusion of fetus is directly proportional to the systolic blood pressure in the uterine vessel. Okay.
Yes, sir.
So gradual reduction of blood pressure is very important. As Anish said rightly, acute fall in blood pressure will cause acute maternal hypotension and can cause acute fetal hypoperfusion, which can cause fetal distress. We don't want that to happen. Hence, NTG and SNP are not the first drugs of choice because they can cause acute or precipitous fall in blood pressure. Okay?
Yeah.
Yeah. So labetalol, IV labetalol, you said 20 milligrams. So 20 milligrams is, each ml contains how many milligrams of labetalol? Or each ampule contains how many milligrams?
So each ml contains 10 milligram.
Is it 10 or 20? How many ampule? I think it's 4 ml ampule, right?
Yeah.
So 5 milligrams.
5 milligram in each ml.
Yeah,
20 milligram. So.
Yeah. I don't know whether there is 10 ml ampule available, but what we have is 20 milligrams in 4 ml, right?
Yeah.
Yeah. So you load 20 milligrams, give over a period of 3 to 5 minutes. Wait for about 5 to 7 minutes to see the response. And again, you can develop the dose. Okay, 40 milligrams, and see the titrated response. Simultaneously, add or step up the oral dose also.
Yes.
Okay, so labetalol IV plus labetalol oral, or as Anish said earlier, nifedipine. Somebody said nifedipine. Anish, you only said nifedipine, right?
Yes, yes, sir.
So how do you give nifedipine? Sublingually?
Sublingual, sir.
So sublingually, it is not recommended now
Absolutely, you're
because it can cause MI or severe hypotension.
bang on. You're right, Reena. Sublingual nifedipine is mentioned or is being discussed only to be condemned. It is a banned route. It should not be given because there is erratic absorption. Suddenly, either there is no absorption or there might be sudden absorption which can cause profound hypotension. Okay. So you give oral nifedipine. Okay. So what is the dose of oral nifedipine?
Sir, 10 milligram tablets come to. We can give
Either you
10
want to give controlled release or sustained release preparation.
sustained release, sir.
Again, when you are managing hypertensive crisis, go for plain nifedipine
Okay, sir.
because I want rapid absorption. Not via sublingual route, but via oral route.
Okay.
So when you're giving 10 milligrams plain nifedipine, you can give 20 mg also with
Yeah.
200 110. And generally, we see the response within 45 minutes. Okay. So, and simultaneously, you can also start controlled release or sustained release preparation also
Okay, sir.
for maintenance therapy. Okay. So, if you have a HDU unit with a good monitoring, you can go for IV labetalol. If you are in a rural setup where you don't have IV labetalol availability, you can always go for
Nifedipine.
regime of magnesium sulfate and oral nifedipine also.
Okay.
Okay. Again, remember that magnesium sulfate therapy that you are giving is not for controlling blood pressure. Magnesium sulfate therapy is for prevention of seizure.
Seizures.
Magnesium sulfate therapy is not for controlling
Blood
blood pressure. Okay. So management of hypertension. What are the goals of hypertension management? Never allow hypotension to occur. Okay.
Yes, sir.
So suppose if you are achieving BP of 120/80 after giving 40 milligrams of labetalol, are you happy?
No, sir. Blood pressure systolic should be around 140.
Yeah. So goal should be the systolic blood pressure should be around 140, diastolic around 85 to 90.
85 to 90.
So if you're getting a BP of 110, 70, 128, yeah, normal aa gaya, chalo, khush ho gaya, aisa nahi. You are causing that is because the utroplasmal circulation is used to that 140/90 and there is no auto regulation. Okay. So overshoot, hypotension have to be prevented. So the goals is systolic BP not less than 140, diastolic not less than 90. Okay, the 140 to 150, 90 to 100 diastolic is what my goal is. And reduction of blood pressure is not more than 25 to 30% every hour. So gradual reduction. Okay.
Yes, sir.
So why do we have to monitor or manage this BP, control this blood pressure?
So because the blood pressure is raised, patient can land up in further complication.
Like
Intracranial hemorrhage.
Intracranial hemorrhage, IC bleeds.
Yeah.
Okay. So systolic blood pressure, uncontrolled systolic blood pressure is directly proportional to the IC bleeds. Okay. And uncontrolled diastolic pressures are directly proportional to pulmonary edema incidence.
Yes, sir.
Okay. So systolic blood pressure, higher the systolic blood pressure, higher the incidence of IC bleeds, higher the diastolic pressure, higher the incidence of pulmonary edema. Again, I was talking to you, the classification, putting the patient in right basket is very important. Okay.
Yes, sir.
Let us say this patient 200/110 is chronic hypertension with superimposed preeclampsia with severe features. Are you worried? Or 200/110 patient is just severe preeclampsia, so superficial, preeclampsia with severe features, not chronic hypertension. So which entity you are more bothered?
So preeclampsia with severe features.
Yeah, see, you have two entities.
Yeah.
The 200/110
Yeah.
in a parturient, which the case you have presented.
Yes, sir.
And you have one more patient, similar history, but she has chronic hypertension with 200/110.
Yes, sir.
So which entity is more dangerous? Are you getting my point?
Yes, understood, sir.
Yeah. So the reason is why this right classification, putting the patient in right basket is very important, because the complications rates vary.
Okay.
So chronic hypertension with severe features, severe preeclampsia features are more dangerous for pulmonary edema. Why?
Because due to chronic hypertension, sir, there are pulmonary changes. They are already, this patient is already in having some of the complications in them.
Like you're right. So what happens to the cardiac modeling in pregnancy?
Sir, cardiac output is increased by 50%.
Yeah, that is
Stroke.
there. So what happens to chamber hypertrophy? See, all chambers hypertrophy in pregnancy.
Yes, sir.
I'm not going to the physiological changes.
Yeah.
And because of chronic hypertension, the left ventricular hypertrophy is more when compared to a
Right.
chronic hypertension lady, right?
Yeah.
So the compliance of left ventricle is reduced in patients with chronic hypertension. Okay.
Yeah.
The diastolic filling pressures are high in patients with chronic hypertension. So this chronic hypertension patient suddenly gets a BP of 200 by 110. The diastolic, the compliance of LV will not increase immediately, and suddenly they go in for pulmonary edema.
Yes, sir.
So incidence of pulmonary edema is 7 times high in uncontrolled hypertension in chronic patients, chronic hypertensive patients. You're getting the point?
Yes, sir.
So the control of blood pressure should be very judicious and very, very rapid, relatively rapid in patients with CKD, I mean chronic hypertension. Okay?
Yes, sir.
Are you getting my point?
Yes, sir.
So putting the patient in right basket is very important. So that was in brief about management of hypertensive crisis, which you need to know.
Yes,
Now
sir.
let us say this patient has LV dysfunction. A heart disease complicating pregnancy. Heart disease complicating
Complicating.
pregnancy with preeclampsia. You're a senior resident, right?
Yes, sir.
That means you're completed MD, right?
No, sir.
Final year
No.
MD.
Yeah.
Yeah. So how do you manage hypertensive crisis in a heart disease patient?
Sir, if patient is having any cardiomyopathy or any heart disease, we need to maintain the heart rate and plus heart rate with the blood pressure. Both should be maintained.
Absolutely. So basically, if you look at labetalol is a negative inotropic, negative
Yes, sir.
chronotropic.
It causes tachycardia.
Nifedipine, no, labetalol will cause reduces the heart rate,
Yes, sir.
but it reduces the contractility also.
Yes, sir.
And nifedipine calcium channel blockers also will reduce cardiac contractility,
Contractility.
cause tachycardia. Okay.
Yeah.
So both are not drugs of choice in managing hypertensive crisis. So
Yes.
the drug of choice in managing hypertensive crisis in a parturient with heart disease with preeclampsia or preeclampsia with hypertensive crisis is hydralazine. Hydralazine, which
Okay.
is a pure venodilator.
Yeah.
It doesn't have any effect on cardiac contractility. Okay.
Yeah.
So cardiac contractility is well maintained. Or the drug which you mentioned earlier, nitroglycerin,
Yes, sir.
NTG, drug of choice. Okay.
Yeah.
But again, whenever you're giving hydralazine, drug of choice or NTG, it is better that this patient is in ICU and have an indwelling
Yes, sir.
intra-arterial monitoring systems, because the patient also has heart disease.
Heart disease.
Okay.
Yeah.
So now let us say this patient develops hypertensive crisis and pulmonary edema.
Yes, sir.
How do you manage?
So for hypertensive crisis,
We have
with,
control the blood pressure with these
yeah,
medications.
yeah.
How
And
do you
for pulmonary edema, sir, we can start oxygen. Actually it depends on the, sir, saturation. If it is just
saturation is around 88%.
okay, so we can give non-invasive ventilation with the BiPAP, and oxygenation is done.
Generally, suddenly you want to give an BiPAP?
So initially we can give oxygen with high flow.
Or high flow oxygen.
Yes, sir.
Position. See, ABC approach.
Diuretic.
ABC approach. See,
Yes, sir.
whenever you have been, you manage any patient, any crisis, what is the approach?
Airway
ABC
ABC.
or CAB, if there is a
CAB.
cardiac arrest.
Yeah.
If the patient is alive, ABC approach,
Yeah.
right?
Yeah.
ABC approach is head-up position, high flow oxygen,
Then we can give.
in pregnancy, left lateral position,
Yes, sir.
and then give
Lasix.
furosemide, and then think of BiPAP or suppose if
Yes,
the
sir.
patient is not able to maintain, right?
Yes, sir.
Are you getting me?
Yes, sir.
So suddenly don't jump to BiPAP. Before that, as Anish said rightly, furosemide. So how much furosemide you want to give?
So patient is already in pulmonary edema, so we can give 40 milligram IV we can give initially.
Generally 1 to 2 milligrams per kg.
Yeah.
Okay. So 1 to 2 milligrams per kg of furosemide, head-up position, high flow oxygen therapy, 15 liters per minute. And if the saturation still does not come up, go for BiPAP.
BiPAP.
Okay. Yeah. So what is the protocol of BiPAP that you follow in your hospital in pregnancy?
So in pregnancy, I have like what's
Anybody? Bhavya? Anish? Samreen?
We keep a IPAP of start with an IPAP for 10 to 12 and EPAP of around 4 to 6.
See, the thing is, one of the things that is very important in pregnancy is the risk of aspiration. Right?
Yes, sir.
So I don't want my patient to aspirate with positive pressure, non-invasive ventilation. So first is strictly 45 degrees head up. Give prokinetic agent, metoclopramide and ranitidine, and start with high FiO2 on low pressures, like FiO2 of 1 and CPAP of 5 and pressure support of perhaps 6 to reduce work of breathing, and gradually escalate the CPAP and pressure support and come down on FiO2. Suddenly, I don't want high pressures to be initiated.
Okay, sir.
Either CPAP, PSV or by EPAP and IPAP. Okay?
Yes, sir.
Are you getting me?
Yes, sir.
Start with high FiO2, low pressures, and slowly escalate the pressures and reduce the FiO2.
Okay.
And simultaneously also give
Antiemetics.
Very, very important. And always head up position.
Yes, sir.
Because we don't want my mother to be at risk of aspiration.
Aspiration.
Okay.
Yeah.
So the point which I want to convey is acute pulmonary edema, acute hypertensive crisis. We have to take this patient for section. Forget that. We have to stabilize this patient, or we have to optimize this patient. And suppose if there is a pathological CTG or acute fetal distress requiring immediate section, cesarean section, optimization and anesthesia has to go simultaneously hand in hand. So if you stabilize the mother, fetus also will get stabilized.
Yes, sir.
You're getting me? So
Yeah.
if you're improving the saturation in the mother, automatically fetal perfusion also will improve and fetal saturation also will improve. Okay?
Yeah.
So try to maintain SpO2 of at least 94 and above, PaO2 of at least 70 millimeters of mercury and above in pregnancy. So what are the concerns from an obstetrician's viewpoint with pulmonary edema? Acute desaturation, acute hypoxia in mother can cause fetal hypoxia.
Fetal hypoxia.
Demise. Okay. So what is the lethal triad for fetal demise? Lethal triad for fetal demise. 3H.
The hypotension, hypoxia,
Hypotension, hypoxia. You're right. And hemorrhage.
hemorrhage.
Maternal hemorrhage, antepartum maternal hemorrhage, antepartum maternal hypotension, antepartum maternal hypoxemia. So 3H in mother can cause fetal demise. So if you can stabilize hypoxia by optimizing oxygen therapy, if you can correct hypotension by preventing overshoot hypotension, if the patient is having hypotension for other reasons, you have to correct it. And you can stop the bleeding, or if the antepartum hemorrhage is there, you may have to rush the patient for a crash section also. Okay.
Yes,
In
sir.
order to prevent fetal demise. So you need to remember what causes fetal demise.
Yes,
So
sir.
if you're targeting treatment towards that and towards stabilize, so if you stabilize the mother, automatically fetus also gets
Stabilize.
stabilized. So you have discussed about management of hypertensive crisis, management of pulmonary edema. So how do you evaluate this patient? Suppose if this patient comes for surgery, how do you evaluate this patient?
Sir, if patient isn't comes with a pulmonary,
You take this patient, your patient, whatever you have presented, this patient, let us say, is for elective cesarean section.
yes, sir.
How do you plan your anesthesia?
Sir, initially I will advise for investigation, sir.
Yeah, so what investigations you want to
Yeah.
advise?
Sir, I will advise for CBC, wherein we'll look for hemoglobin and platelet count, since patient could be in thrombocytopenia. Then renal function test to know the creatinine value. Since
Anything else you want to know from CBC?
sir,
Which,
WBC count, patient could be in infection, sepsis also.
anything else? So generally,
Plate.
our mind is fixated. CBC, preeclampsia, we look for platelets, we look for HB.
Sir, hemo and hemolytic
You're right.
angiopathic hemolytic
Microangiopathic hemolytic.
microangiopathic hemolytic.
MAHA. So what do you look for? What are the features of MAHA in CBC? Cystocytes, bursaries, broken RBCs. Okay. So always look at peripheral smears. Always look at peripheral smear. Generally, we have a tendency to look for
Only platelet.
and platelets.
Yeah.
Now I'll say this in this patient, hemoglobin is 13.8 grams. WBC is 14,000. Platelets are 74,000.
Yes, sir.
Are you concerned?
So platelets are less and hemoglobin is 13.4. These patients have hemo concentration, sir. Means they are so platelet is less, so patient is in thrombocytopenia.
So what else you want to look in the investigations?
So besides CBC, besides CBC, sir, we'll go in for liver function test, wherein we'll see for AST, ALT, and LDH. If patient is having liver HELP syndrome, means elevated liver enzyme, low platelet, we'll come to know that. Then, sir, renal function test, wherein we'll come to the serum creatinine. Then coagulation profile, sir, where INR and prothrombin time. And so these are and serum electrolytes, sir.
Why electrolytes are important?
Sir, to know the serum potassium and sodium level.
You're right. Excellent. Why potassium?
So whether patient is in hyperkalemia or hypokalemia. So
what is it, the implication from anesthetic viewpoint?
pardon, sir?
What is the implication from anesthetic viewpoint?
That if patient is in hyperkalemia, we already, if patient is in emergency, we are taking it. So we give scoline to prevent the aspiration. I mean, we do follow the RSI technique and we give scoline. So if patient is in hyperkalemia, we won't be able to give that.
Yeah, so excellent. So electrolytes are very important. So let us say in this patient, hemoglobin is 13.8 grams, SGOT, SGPT is 110 and 120, LDH is 720, INR is 1.6, APTT is 42 seconds, creatinine is 1.1.
Yes, sir. The patient is in HELP syndrome, sir. With
So how do you classify HELP syndrome?
Sir, bilirubin will be more than 1.2 with ALT.
How do you classify HELP syndrome?
Sir, it is hemolysis, elevated liver enzyme, and low platelet. And
Who coined this term?
yes, sir.
Who coined this term?
Sorry, sir, I don't know.
Ashbaugh, yeah. So how do you classify HELP syndrome?
Sir, we see the serum bilirubin.
So class 1, class 2, class 3, partial, complete, incomplete, CBIS classification, BAS classification, Mississippi classification. Are you aware of those things? Anybody? Mississippi classification, CBIS classification, partial HELP, complete HELP, evolving HELP. So basically, HELP, I would say it is important that any parturian with preeclampsia or hypertensive disorders always get LFTs, KFTs, and CBC done. Coagulation profile, probably we reserve it if the platelets are less than 1 lakh. Okay.
Yes, sir.
The reason is 70% of HELP syndromes are biochemical derangements. They don't have overt coagulopathy. Only 30% of HELP syndrome, they have frank coagulopathy with hematuria, with bleeding gums, or any of those abruption and the overt presentation. Okay.
Yes.
And the moment the patient goes into HELP, the deterioration is very, very rapid. And it requires immediate termination of pregnancy. Okay.
Yes, sir.
So it is the moment you get any patient at the time of PSC, always advise CBC, KFT, LFT, CUE also. These are very important. Am I clear?
Yes, sir.
And try to pick up asymptomatic HELP syndrome.
Yes, sir.
Asymptomatic HELP syndrome. Okay.
Yes.
So it is very important that you classify HELP syndrome as class 1, class 2, and class 3. Class 3 is platelet count of it is based on platelet count. More than 1 lakh, but less than 1.5. And class 2 is between 51,000 to 1 lakh, and class 3 is less than 50. I mean, class 1 is less than 50,000, class 2 is 51,000 to 1 lakh, and class 3 is 1 lakh to 1 lakh, 1.5 lakhs. So our idea is, as the patient goes to class 1, the progression from 1 lakh to less than 50,000 can happen very rapidly. So we need to terminate the pregnancy before they progress to class 1 HELP syndrome. Because the morbidity and mortality increases 7 times when the patient goes to class 1 HELP syndrome, where the patient goes into fulminant frank coagulopathy with DIC, with acute kidney injury, with CNS complications. So always, all preeclampsia, we need to look for HELP entity. Again, I must tell you, 15% of HELP syndrome will not have hypertension. And 15 to 20% of HELP syndromes can be a postpartum presentation. 15% of patients can throw fits after surgery or after delivery, postpartum eclampsia. Need not be antepartum. So these patients have to be monitored serially. Okay. Yes. So HELP syndrome, we need to proactively investigate for it. And once it is HELP syndrome, the treatment is termination of pregnancy.
Termination of pregnancy.
Once it is preeclampsia with severe features, the treatment is termination of pregnancy, but you have got some time to stabilize the mother, optimize the mother. HELP syndrome also better to have optimize the mother. Stabilization may take time. Optimization is what is important. You got my point?
Yes, sir.
Optimization versus stabilization. Okay?
Yes, sir.
Both are different. Stabilization is complete resolvement of the pathology and control of primary pathology. Whereas optimization is optimizing so that the patient can be navigated safely through surgery or anesthesia. Okay. Yes, when BP has come to 160, that's fine for me. I can take up the patient for surgery now safely. Very important. Other important feature, why do you want to investigate is for planning neuraxial anesthesia.
Yes, sir.
Okay. So I want to know the platelet count. So in this patient with platelet count of 72,000, INR of 1.6.
Sir, platelet count more than 80,000. We can go ahead with regional, but between 50 to 70, between 50 to 70, 80,000, it is, and plus INR is 1.6. I will go ahead with general anesthesia, sir.
I would add a bit of Anish, you can also join in. Like let us say this patient is Malampati grade 4 and has hoarseness
Okay.
and these parameters.
So for platelet, it's a
70%
risk and benefit actually to see between 50 to 80,000 when we see the platelet count. INR, sir, we can give FFP to reduce the INR, but then increase it will again increase the volume. Hello?
Yeah, I'm listening.
Yeah.
What type of anesthesia you want to plan?
So for this patient, if I have to take it just means as like instantly, then I'll go ahead with MPC 4, sir, you said, no?
MPC4 and hoarseness and OSA is there. Platelets of 72,000, AST elevated, ALT elevated, INR is 1.6.
Sir, we can go ahead with general anesthesia, but keeping all our difficult airway cart ready with video laryngoscope, bougie, small size tube, everything should be ready then.
See, when you have these things, no?
Yeah.
Again, you can open up the discussion with the team.
Yes, sir.
Here you have a difficult intubation, very, very difficult intubation with hoarseness of voice, and versus risk of neuraxial hematoma with regional anesthesia.
Yes, sir.
Okay. The risk of regional anesthesia is relatively less. Neuraxial hematoma is relatively less, relatively low, even with borderline coagulopathy.
Yeah.
So, but risk of difficult airway is very high.
Hi.
So we need to balance both the things. Okay.
Sir.
So open up the discussion with the family.
Okay.
So this is a safer type of anesthesia, a record of phenomenal record of maternal safety, whereas phenomenal risks of difficult airway intubation, failed airway. So considering risk versus benefit, this is still a safer option. But yes, remote possibility is there. So explaining to the patient, informed consent is very important. Okay?
Yeah.
Informed consent, discussing with the patient and the family. Suppose the patient is illiterate, uneducated, then involving the obstetric team and the relative who is a little more knowledgeable and doing a audio video recording and then planning a safe regional is still a better option, safer option.
Okay.
But if you feel airway is good, intubatable, no hoarseness, then as you rightly said, GA is a safer option. Okay.
Yes, sir.
Now I'll give one more scenario, Reena.
Yes, sir.
This patient, hemoglobin is 13.8, AST elevated, ALT elevated, almost in 500s. LDH is in about 1,000, and INR is 2.4.
Okay.
Platelets are 52,000. How do you plan your anesthesia?
So in this case, it will be general anesthesia only.
Yeah. How do you plan your GA?
Yes, sir. So, sir, after taking the high risk hit,
Potassium is 5.8. Creatinine is 1.2.
okay. Sir, after taking the high risk consent,
When you say high risk consent, what are the things? I'm worried. I'm the patient's partner.
Yeah.
Worried. So what all you want me to? What all you would explain to me?
Sir, yeah, I'll explain to the relative that life of mother and baby both are important, but we'll try to save both of them. But and plus, sir, patient post-operatively, patient can go on ventilator. So
So
that
what
I'll
is the risk of ventilation, madam?
pardon, sir.
What is the risk of ventilation?
Sir, patient is having there is an increased risk of difficult airway, and plus there is laryngeal edema in these patients. So patient can go on ventilator
So
post-operatively.
can you risk stratify the risk of ventilation by doing any investigation? You're right.
Yes,
Risk
sir.
of mechanical ventilation you are explaining to the patient. I'm very happy. But can you risk stratify the incidence by doing any specific targeted investigation, which as an anesthesiologist, we are very, very familiar. Day in and day out in ICU, we keep doing this investigation. Blood
Sir,
gas,
USG,
blood
like,
gas, blood gas,
ABG, yes, sir.
ABG. ABG will tell you if the mother has severe metabolic acidosis, then she's going to take a longer time to recover from anesthesia. Okay?
Yes, sir.
So there is a way to put it in a diplomatic way, so that because to say that anesthesia is safe, that you can always say this patient, okay, this patient is on magnesium sulfate therapy to prevent seizure.
Yes, sir.
So magnesium can interact with anesthetic drugs and you end up with delayed recovery. Not because of anesthesia, but because of this drug. And this drug has to be continued. We cannot stop this drug. So you're sort of attributing or trying to add one more cause for delayed recovery, right? Magnesium,
Yes,
then metabolic acidosis, then difficult airway. Okay, so that is one thing. What is the other thing that you want to explain to me? Consent is very important. Informed consent is very important.
Intra complications that can happen.
Many times which we say that consent, we don't take proper consent, but consent is very important. And as an anesthesiologist, we are not involved in much of talking unless you do critical care, where you day in and day out, we keep counseling with. So the art of talking is very important. The ease of flow of sentences, reassuringly telling the worst complication, reassuringly. If you are pausing and if you are pondering and if your thought process, the confidence level in the patient attendants will go. They may think that you're an incompetent person. So you have to be confident, dogmatic, reassuring, at the same time, giving worse or guarded prognosis. You got my point?
Yes,
So what all you want to explain? And any specific thing that you want to do in this case before you take up for cesarean section?
Sir,
wouldn't you want to correct the coagulopathy before,
yes, sir.
before taking up?
Yeah. You can give sir FFP, FFP is given, sir, to correct the INR and 15 milligram per kg.
Anything else you would like to do?
So
You're at breech candy. You can do thromboelastography,
TEG.
TEG, and give a targeted therapy, right?
Yes, sir.
Tranexamic acid can be given. FFP 15 mg per kg, 15 ml per kg.
15 ml per kg.
Yeah. Anything else you would like to do?
Sir,
see, these pauses will come either because you have not managed enough cases or you're not confident, or probably you're not well read, or probably you're just not prepared for what. But I'm sure you're well prepared. So the thing is, we need to know, okay, this patient's blood group is B positive. I need to have enough blood and blood components in hand. I need to have enough blood and blood components adequately reserved.
yes, sir.
Okay. And be prepared for massive blood loss.
Blood.
So I would like to know plasma fibrinogen levels also, because INR is 2.2,
Yes, sir.
platelets are low, APTT is 48 seconds. So obviously you are looking at a patient with help with DIC. Okay.
Yeah.
So I would like to correct the coagulopathy and then take up the patient. But suppose if this patient is for stat cesarean section, wherein the fetal distress is also very immediate, delivery has to happen. Both have to go simultaneously. Correction, optimization, stabilization, and anesthesia and delivery. Everything has to go simultaneously, hand in hand, right?
Yes.
But you can check with the obstetrician if you have a window of optimization, at least give FFPs and at least one SDP, or 58,000 is still okay for cesarean section, but see that platelets are available
Yes, sir.
on the agitator. Am I clear on this?
Yeah.
And if the fibrinogen is less, so what is the level of fibrinogen you want to maintain in this case?
So it should be between 250 to 300, sir.
In pregnancy, in this patient with coagulopathy? Yeah, at least more than 220 milligrams per
Yeah.
deciliter. Okay.
Yeah.
Yeah. 50 need not be 250 or 300 because, but at least around 200 plus. Okay.
Yeah.
So either you can go for PT, APTT, INR, you can go for point of care testing, thromboelastography, whichever way. I don't want to go into the management of hemorrhage and this thing, but basically, HELP syndrome is one entity that you need to be very thorough about it. Also explain the risk of RRT, renal replacement therapy, need for dialysis. Okay.
Yes, sir.
You can explain that now most of the patient attendants are tech savvy.
Hmm.
So you can ask them to Google search complications of HELP syndrome. They themselves will come, "Arey, ye bhi hota hai, ye bhi hota hai, ye bhi hota hai." But one of the very important thing in preeclampsia without severe features and HELP syndrome, with normotensive with HELP syndrome, preeclampsia without severe features,
Yes, sir.
would you like to start magnesium sulfate therapy? 150/90. No headache, no epigastric pain. Reflexes are normal. No irritable, serious irritability.
So we can start magnesium as a prophylactic.
Like there is no need actually.
Okay.
Okay. 140/90, single reading. No imminent signs. But you have 140/90 with INR of 1.5, SGOT, SGPT of hundreds, LDH of 700, platelets of 90,000. Would you like to start max self? BP is 110/70 or 140/90. Would you like to start max self? No imminent signs.
If investigations are haywire, sir, we can start since patient
Normal.
can.
Normal. Investigation is like borderline. Everything is fine otherwise. No imminent signs. No headache, no irritability. See,
No, sir.
the moment you put label of HELP syndrome,
Yes, sir.
magnesium sulfate therapy is mandatory. Even if the mother does not have any imminent signs. Because the patient can go in for coagulopathy very rapidly, and with coagulopathy and tonic and clonic seizure, intracranial hemorrhage is very common.
Yes, sir.
So magnesium sulfate therapy is mandatory in HELP syndrome, irrespective of the blood pressure, irrespective whether the mother has imminent signs or not. Am I clear on this?
Yes, sir.
Okay. Now, this lady has come for cesarean section. How do you give GA?
Yes, sir. Sir, after taking so this high risk patient.
Yeah, this patient, high risk patient. Yeah, तुम्हारा patient ले लो. Take
Okay.
your.
Yes, sir.
I'll just take one call if you don't mind.
Yes, yes, sir.
Sorry. Sorry. So, how do you give a safe GA?
Yes, sir. Sir, after taking the high risk consent, informed consent from the
You have taken
relative.
informed consent. You have explained me the risk of.
Yeah. I'll Antiemetic prophylaxis, I'll be giving sir with metoclopramide.
Antiemetic prophylaxis.
Yeah, anti-aspiration prophylaxis.
Yes.
With the pantoprazole, 40 milligram, and metoclopramide, sir, 10 milligram. Then I'll be taking 2 wide bore IV, and I'll prepare my OT. I'll keep my all difficult airway cart, airway trolley ready, machine checked, all suction ready, and sir, then after after checking,
When you say suction ready,
yes,
what do you mean?
sir, checking the suction pressure, it should be around 300 to 400, sir.
Minus 400 and above.
Yeah.
Don't say 300, 400. 300, 400 can be positive also, no?
Yes, sir.
So minus 400 and above.
Minus 400, sir. Yeah.
And Yanko's suction.
Yeah.
Okay, yeah.
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 Then I'll wheel in the patient, sir. First, I'll attach all the monitors, sir. ECG, blood pressure, ECG, NIBP, pulse ox. Then I'll start with the pre-oxygenation with 100% oxygen. For this patient, sir, we'll pre-oxygenate for more time since apnea time will be less since FRC is reduced in these patients. So I'll pre-oxygenate. Yes, sir. Hello, sir.
When you say more time, how much
3
more?
to 5 minutes, sir. 5 minutes.
What are the different methods of pre-oxygenation?
So we can by the auxiliary port of oxygen, I can put on the nasal prongs and give oxygen of 15 liters. Then I can use high flow nasal oxygenation, sir, and giving oxygen through the mask holding.
So basically, let us say this patient had pulmonary edema, resolving pulmonary edema, SATs are still about 92, 93%.
Yes, sir.
So how do you pre-oxygenate this patient? As you rightly said, HFNC.
Yes, sir.
HFNC, high flow nasal cannula.
Yes.
Okay.
Yeah.
Or CPAP, continuous CPAP.
Yes, sir.
Continuous CPAP for about 5 to 7 minutes, which improves FRC. Or the pre-oxygenation has been redefined and it is labeled as para-oxygenation or peri-oxygenation.
Yeah.
Okay.
Yeah.
So not only we are giving pre-oxygenation, but also during apneic period, we are giving nasal cannula. So the apneic oxygenation is happening.
Yes, sir.
So it is basically peri-oxygenation. So we want to see that increased oxygen reserves continue even during apneic time. Okay.
Yes,
so either you can give oxygenation by CPAP for about 10 minutes, head up position with ICU ventilator, because unless you have very advanced anesthesia workstation like ISIS or ZIS, our anesthesia workstation will not be able to give NIV.
Yes, sir.
Bring NIV into the theater, we give BiPAP through the things, and once you give propofol induction agent, once the patient becomes apneic, you take over with Bain circuit.
Yes, sir.
But at least 7 to 10 minutes with head up position, or HFNC for at least minimum 5 to 7 minutes. The advantage with HFNC is you maintain the humidification, like Thrive and other things, right?
Yeah.
Or you give your regular pre-oxygenation with Bain circuit, or this Mapleson A circuit with HFNC, like high flow nasal catheters, 15 liters. Okay, that is the commonest thing that we do in our. That should be the routine. Make that a routine.
Yes.
Because what happens is, one odd case when if it is not in your culture, you tend to forget. So the moment pregnant patient comes, make it a routine.
Yes, sir.
And what happens is, like, see, when you're working in a large team, Reena uses nasal catheter and Anish will not use nasal catheter. The onlookers, the bystander technician feel that, अरे Reena is कभी ज़्यादा डरती है, हमेशा ये लगाती है, Anish लगाता नहीं है, एकदम बहादुर है. So when you have uniform protocol, whether Anish comes or Bhavya comes or Reena comes or anybody XYZ comes, this is the method I follow. The same culture develops in the team. You got my point?
Yes, sir.
So when everybody does or talks the same language, the onlookers or bystanders will not say that, अरे ये anesthesia नखरे ज्यादा करता है, ये होना है, वो होना बोलता है, दूसरे लोग कुछ बोलते नहीं है.
Yes, sir.
So we need to develop that culture in the theater. Is very, very important, so that everybody does safety protocols.
Yes, sir.
BiPAP, CPAP, HFNC, all these things are very important as a respiratory prophylaxis. Okay.
Yes.
Now, how do you induce the patient?
Yes,
So
sir.
you're peri-oxygenating the patient.
Yeah.
And how do you induce the patient?
Sir, I'll give pre-medication with injection glycopyrrolate 0.2 milligram and injection fentanyl 2 mics per kg. Then induction I'll do with injection propofol, sir, 2 milligram per kg in titrated dose. Sir, I'll give slowly. And once the patient is under, I'll check for the ventilation. Just a small puff since patient is at risk of aspiration. So I'll give scolin, sir, 2 milligram per kg.
Potassium was 6 millimoles.
Pardon, sir?
Potassium was
Potassium. Okay, sir.
potassium was 6 millimoles, na iska?
Yes,
They
sir.
want to use hexamethonium.
Pardon, sir?
The potassium was 5.
Yes, sir. No, then we cannot use, sir.
Then what do you want to?
The single therapy rocuronium can be used.
Rocuronium can be used, sir, but it will be again long acting.
Rocuronium is fast acting, no?
No, I mean to say, it will act fast, but sir, the next dose requirement is after 45 minutes. Something.
What is the choice you have?
Sir, rocuronium only then.
Then
So I'll give rocuronium.
the
Where,
dose
sir?
of
So it's 0.3 to 0.8 milligram per kg.
yeah. Then
Then, sir, after patient is relaxed, I'll use the RSI technique by giving a pressure at the cricoid cartilage. 1% will give that. And I'll use a small size ET tube. And after doing a gentle, before that, sir, to abdun the laryngoscopy reflex, I'll give Loxicart 1.5 milligram per kg. After that, sir, I'll do the laryngoscopy with video laryngoscope. And a small size ET tube is preferred, sir, in pregnant patient. After intubating the patient, I'll inflate the cuff and put the patient on ventilator. My maintenance will be, sir, oxygen nitrous and
I'll
give a
pause. I'll give a pause. You
Pardon,
have, I'll give it a pause. You
Yeah.
have done RSI required pressure 60 seconds. You waited.
Yeah.
By giving the rapid sequence, you didn't ventilate for 60 seconds. You're not able to intubate the patient.
Okay. Sir,
Now patient starts desaturating.
I'll again ventilate the patient, sir.
So could you have circumvented this?
Pardon, sir?
See, generally what I recommend and what I teach all my fellows is
Yes, sir.
go for modified rapid sequence.
Okay, sir.
Don't go for rapid sequence.
Okay.
That means once the patient is under with propofol and rocuronium or hexamethonium, whatever you are giving,
Yeah.
and continue gentle IPPV with oropharyngeal airway.
Okay.
Insert oropharyngeal airway and
Okay.
continue gentle IPPV, because most of the anesthesia workstation, they have airway pressure gauge.
Yeah.
And see that the airway pressure do not increase beyond 20 centimeters of water.
Okay.
So the 60 seconds, instead of apnea, you are giving positive pressure.
Positive pressure.
But the apneic time is prolonged.
Okay.
Okay. And as you rightly said, the best attempt, the first attempt is the best attempt. You took a video laryngoscope straight away and you have intubated the patient.
Yes, sir.
I would do one more thing. I will see that Dr. Kalpana is called in advance.
Call for help, sir.
Right.
Always for these patients.
Always call for help, extra hand at intubation.
Yes, sir.
When I say extra hand, the person who is better than me.
Yes, sir.
Not one extra hand just for like XYZ income को पा जाएगा, ऐसा नहीं. कोई ऐसा व्यक्ति चाहिए जो हमसे बेहतर है वो. ठीक है?
Okay.
So you need to have somebody who is better than you in terms of skills.
Yes, sir.
Okay. Then the moment you intubate the patient and inflate the cuff, what is the first thing that you look at?
So we look at the ETCO2 and check the air entry.
Yeah. No, look at DTCO2.
Yeah.
6 cycles. At least
Yes,
6 cycles. Okay.
Yeah.
Then what do you look at?
Uh, then we check the air entry.
No.
And
I always teach, look at ETCO2, minimum 6 cycles,
yeah,
6 breaths, and then simultaneously also look at peak airway pressure and plateau pressure.
yes, sir.
Peak airway pressure and plateau pressure. Suppose if peak airway pressure is high, then you check the level of tube.
Tube, yes, sir.
Okay.
Yeah.
So what is happening is you are checking everything. Air entry, bhul jana ye zamane mein.
Okay, sir.
I mean, air entry is fallacious actually, I would say. So you look at ETCO2 trace, increasing ETCO2 trace, peak airway pressure, plateau pressure, and see that the black mark of the endotracheal tube was at the glottic level. Then 17 to 18 centimeters or 18 to 19 at the angle of the mouth in females is what is desirable. Okay.
Yes, sir.
Unless the patient is very short stature or a very short neck, endobronchial is very rare.
Yeah.
But still, बाद में to satisfy yourself, put stethoscope on both the axilla or left axilla is important. One left axilla auscultation is good enough. Okay, then you fix the tube and then maintenance.
Yes, sir.
Okay,
yeah.
So this is very important. And what about magnesium sulfate? Would you like to continue magnesium sulfate?
Yes, sir. Intra magnesium sulfate is continued, but
or you want to stop?
Yes, sir.
You want to stop?
No, I'll continue with magnesium sulfate. Sir.
What else?
Sir, then we'll give my choice of non-depolarizing muscle relaxant is injection atracurium.
You are given rocuronium now. Why do you want to give atracurium?
Sorry, sir. Yes. So I'll continue with rocuronium, sir, and maintenance on oxygen.
No, let us take a hypothetical. You are not able to intubate.
Okay, sir.
What do you do?
Sir, if not, I'll ventilate the patient again, and second attempt of intubation I'll do. Still, I'm not able to intubate. Then
I'll see that the best hand comes.
Yes, sir.
And the best technique. You can if the Kalpana is confident, she'll ask you to
Yes, sir.
मैं ठहरती हूँ जरा आप और एक बार try करो.
Yeah.
But anything else you want to keep as a standby?
Supraglottic airway, sir.
Yeah.
Third generation.
Third generation. कौन सा है third generation आपके पास?
The Baska.
Baska is there?
So yes.
You are using it regularly?
No, I've not used it, but it's there, sir.
Yeah. The second generation also suffices.
Yes,
second
sir.
or third generation LMA. Okay. Yeah. Right. So the backup plan is very important. Suppose the Baska is not, you are not able to insert Baska, you're not able to insert laryngeal mask, you're not able to ventilate, patient is desaturating.
Sir, cricothyrotomy.
Anything else you can do in this case?
Fiber optic.
Fiber optic.
Patient oropharyngeal is mold. Fiber optic में क्या है? You need to do fiber optic a day to get fiber optic in this
Yes,
situation.
Sir.
Anything else you can do? Reverse.
Yes, sir.
What is the reverse?
Sir, Sugama Dex is used if rocuronium has been used.
How much?
16 milligram per kg. So that
So
it acts instantaneously.
Option you have. Okay, theoretical option. Abhi I have not
Yes, sir.
tried. I have not been, fortunately, I have not had that situation. But that is one option that is available.
Yes, sir.
Okay. Sugamadex. Okay. Now, there is one more option that is available. Intubating
LMA.
without muscle relaxant.
Yes, sir.
Okay. So, remifentanil, if it is going to come in our market very soon, which we have been waiting for long, you can go for a intubating dose of remifentanil, laryngoscopy, intubate the patient. If you can't intubate anyway, remifentanil is off within 3 minutes. You got my point?
Yes,
so,
sir.
proper remifentanil combination for avoiding neuromuscular blocking agent also. That option also is there.
Yes, sir.
Just because you are a fellow, I mean, senior resident, you need to keep all these options now, right?
Yes, sir.
So anyway, forget about all these things. We have discussed about HELP syndrome, stabilization of HELP syndrome, correction of coagulopathy, wide bore cannula. Now this patient has recovered from anesthesia quite well. This patient develops oliguria in the postoperative period.
So, it could be due to the magnesium sulfate toxicity, but we need to check the other parameters. So patient is has been extubated and fully awake, so we can check in for the respiratory depression, urine output, and patellar reflex. And if toxicity is there, means if serum, we'll check in for the serum magnesium.
What are all the causes of oliguria? Post-operative
So
oliguria.
one could be the kidney dysfunction, which already patient's creat is on the higher side. So tubular dysfunction due to the endotheliosis it occurs, and that could be the cause.
Worsening of acute kidney injury
Yes, sir.
is one cause.
Yeah.
What is the other cause?
Magnesium sulfate toxicity, sir.
Magnesium toxicity. What is the other third cause?
Patient could be in DIC. Or
Is she bleeding? Hypovolemia.
yeah, sir.
What is the fourth cause? And the commonest cause?
Hypotension. Right.
I'm talking about oliguria.
Yes, sir.
What is obligatory oliguria?
When patient is not able to pass urine due to
Obligatory oliguria is an entity specifically seen in pregnant patient who receives oxytocin.
okay.
The oxytocin you're giving as a prophylaxis, right? We
Yes, sir.
didn't speak much on that because again the discussion can get prolonged by another 1 hour. But what I wanted to emphasize is oxytocin that you use for prevention of postpartum hemorrhage following delivery
Yes, sir.
can have SIADH like action.
Yes, sir.
Itself can cause oliguria.
Yes,
So
sir.
this oliguria does not require any treatment. It is transient in nature, and 8 to 10 hours it resolves on its own. You got my point?
Yes, sir.
But in this patient with preceding AKI, preceding hemorrhage, bleeding, you need to, before you dump it as obligatory oliguria, you need to rule out a dual differential diagnosis.
Yes, sir.
Okay.
Yes.
And importantly, volume assessment. Okay,
Yeah.
what is the hydration status? 13.8 hemoglobin is a hemoconcentration.
Yeah.
Is intravascular dehydration state.
Yes, sir.
Okay. So you need to do ultrasound guided dynamic assessment of fluids,
IBC.
either IVC
Yeah.
or LV contractility or urine output. Those things are very important. Okay.
Yes, sir.
So assessment of fluid status dynamically, dynamic assessment of fluid status has to be done. Is that clear?
Yes, sir.
And fluid replenishment and fluid challenge can be given 5 ml or 10 ml per kg crystalloid, and you can give furosemide as a if the patient is still oliguria.
Yes, sir.
Antepartum period, the role of furosemide is only in pulmonary edema, no other indication.
Yes, sir.
Suppose if you have a patient with severe preeclampsia with oliguria in the antepartum period, is there a role of furosemide?
So with oliguria,
Preeclampsia with severe features.
sir, if patient is on magnesium sulfate, then it could be the toxicity.
No, patient is magnesium toxicity is not there.
Sir, kidney involvement is there if severe features are there. So
Kidney
we
is
can.
not involved,
Okay.
but oliguria is there. So, is there a role of fluid challenge? Is there a role of furosemide?
So fluid challenge we can give to the patient.
See, again, I must tell you, antepartum period, preeclampsia with severe features, with oliguria.
Yes, sir.
There is no role of fluid challenge.
Okay.
There is no role of furosemide.
Okay.
Do a blood gas. If there is metabolic acidosis, it is better to remove the delivery. I mean,
Yes.
plan a delivery. Because by giving furosemide, you are further depleting the intravascular compartment and you are increasing the fetal insufficiency.
Yes, sir.
Okay.
Yeah.
So the only indication of furosemide in the antepartum period is acute pulmonary edema.
Pulmonary edema.
No other indication. Postpartum period, you can always give because there is no harm in risk versus benefit. You can give 40 mg elastics because just in case, just to cause that extra pressure on the tubules, you can. But before you give furosemide, see that you rule out hypovolemia.
Yes, sir.
Okay, so dynamic assessment of fluid. So fluid management, how do you manage fluid in these cases? What instructions you want to give post-operative period?
Post-operatively,
Give
we'll,
instructions in your hospital.
pardon, sir?
Post-op instructions, obstetricians लिखते हैं, आप लोग लिखते हैं,
So, obstetricians right now.
आप लोग नहीं लिखते हो.
So, full fluid we don't write. We write for the analgesia what needs to be given.
So what? Suppose if you write the complete post-op instructions, what all you want to give?
So, post-operatively, then we'll continue with the anti-aspiration which were being given. Then fluid, sir.
See,
The
NPO for how many hours?
patient will be NBM after since my patient has been extubated and patient is conscious oriented and doing well. So patient will be NBM for 4 hours. She was under general anesthesia. And it reached
6 hours. Come out of that mindset and mind blocks.
okay, sir.
Gone are the days. If my patient sensorium is good, is my patient able to cough? Is my patient stable hemodynamically? Why do you want to starve her for 4 hours?
Okay.
Don't you want to put this patient under ERAS?
Yes, sir. ERAS protocol.
ERAS protocol. So NPO for 2 hours only.
Okay, sir.
Because reflexes are completely recovered.
Yeah.
Pharyngeal reflex. See, that 4 hours is obtended pharyngeal reflexes, obtended laryngeal reflexes, obtended sensorium.
Yes, sir.
But because the sensorium is good, no hyperirritability and no excitability, I don't anticipate seizure because magnesium sulfate is stable. Patient is under on maxillary therapy. Despite that, she can throw it. That's a different story. So short NPO period.
Okay, sir.
Okay, you got my point. Start with clear liquids.
Yes, sir.
Then what is the next instruction?
So next is for the medications.
IV fluids.
IV fluids, sir.
What IV fluids you want to give?
We can give ringol-acted and normal saline. 70 to 80 ml per hour can be given, sir.
Why not 5% dextrose?
We can give 5%. 5% less.
You want to give 5% dextrose?
No, sir, we don't give. Normally, we give ringol-acted or normal saline is given, sir.
No, there is no 5% dextrose. Why?
It will increase the osmolarity again and then.
Increase or
Cerebral
decrease?
edema
Sorry.
can cause.
Anish, bolo?
Cerebral edema can
Yeah.
Yeah, basically 5% dextrose is a hypoosmolar solution.
Hypoosmolar, yes, sir.
What is the osmolarity of 5% dextrose? What is the plasma serum osmolarity in pregnancy?
So normal osmolarity is 280 milliosmoles.
85 to 295. In pregnancy? What is tell me. See, in pregnancy, because there is a plasma volume expansion,
Yes, sir.
there's a plasma volume expansion, the osmolarity is slightly less, about 280. So what is the osmolarity of 5% dextrose? 250.
250, sir.
Hypoosmolar.
Yes, sir.
And once dextrose is metabolized, it is further reduced.
Yes, sir.
Okay, so as Anish said rightly, it can cause cerebral edema.
Yes, sir.
Okay, so you need to be very clear. Okay.
Yeah.
Then.
So
Sorry,
then.
how much saline? What is
Yeah.
the volume? How much? 1 to 1.5 ml, not more than that. Okay.
Yeah.
How long you want to give?
So for first 24 hours, can give.
As long as once the patient resumes you can
Full
stop.
diet is started, then we can stop it.
So if the patient is able to take adequate orally, then there is no need. Okay.
Yes, sir.
So now, okay. Now when NPO is over, fluids are over. And what next?
So medications.
What medication?
Antihypertensive patient, what was there, we can continue, and magnesium sulfate therapy.
Continue magnesium sulfate therapy.
Yes, sir.
How long you want to continue magnesium sulfate
So
therapy?
for 24 hours. 24
hours.
to 48 hours.
24 hours from the time of initiation?
So 24 hours from extubation.
From extubation, from the time of delivery.
From the time of delivery.
or from the time of starting? See, 24 hours from the time of delivery.
Yes, sir.
Or if there is no delivery happening, from the time of initiation.
Okay, sir.
And at the end of 24 hours, if the patient is still excitable and irritable, like exaggerated reflex, they continue for another 24 hours.
Yes, sir.
So what category does magnesium sulfate belongs to? Pregnancy category?
Sir, drug.
Yeah. You know the category, class A, class
Criteria A, B, C, D
Yeah.
is there.
X. Yeah,
It belongs to, sir, B.
you're right. B. So magnesium sulfate therapy can become D
Okay.
and become D in what conditions? If you look at the literature, magnesium sulfate therapy was given sometimes for 3 days, 4 days.
Yes, sir.
If it is given beyond 72 hours, it can become category D because it can cause severe fetal osteoporosis.
Fetal.
Anyway, that's a side thing, but it's a category B drug, safe drug.
Yes.
Okay.
Yeah.
And what else you want to give?
So antihypertensive, magnesium sulfate, and whatever goes there, we can continue with that.
What else?
So then pitocin will be continued.
Pitocin. Okay. Then
Sir, analgesia, post-op analgesia.
antibiotic देना नहीं है क्या?
Pardon?
What antibiotic you have given?
Antibiotic. Yes, sir. Sir, depending on what the surgeon asks for.
See, the dependency on surgeon should start depending on the anesthesiologist.
Okay, sir.
The surgeon should get these mind blocks which you are getting.
Okay.
There is one way to make yourself indispensable. अब क्या लिखूं और क्या दूं, fluid कितना दूं, pain क्या दूं, antibiotic भी यह दूं क्या? It should come from you. You got it?
Yeah.
So what happens is the dependency factor on you from the surgeons increases. I'll be happy with that.
Yes, sir.
Okay. But that can happen only when you master the things.
Yes, sir.
I want you to give this antibiotic only for this long. One dose is enough. Now I want to give for 24 hours. Now I want to give for 5 days. So for you to tell those things, you need to master the things. So that is transition of anesthesiologist into perioperative physician and into a intensive care, critical care specialist.
Yes, sir.
So you need to know a lot about antibiotics also. When to start, what to start, when to stop, otherwise we become a slave mentality. Slave mentality is whatever the surgeon says, we listen to them. Okay, most of them they are right. I don't say that. I don't deny. We also have gone through that phase. But slowly, at some point of time, with our knowledge of critical care, we can let the surgeon confine themselves to surgical skills and surgical related things.
Yes, sir.
Entire perioperative things you take over. It's an extra responsibility, but it gives a lot of pleasure. Okay?
Yes, sir.
You got my point. So,
Yes, sir.
so antibiotics. So in this case, whatever prophylaxis you follow in your hospital, you continue. But if it's a surgical straightforward elective section, one stat dose is enough before delivery. Okay?
Yeah.
So fluids, antibiotics, antihypertensives, magnesium sulfate therapy, and analgesia.
Analgesia.
I mean, this is the most important point. What analgesia you want to give?
Sir, in this patient, we'll avoid NSAIDs.
Yes.
I'll go.
Yes.
Sir?
You want to avoid NSAIDs? Yes, very good.
Then I'll go. We'll be giving perfalgan, paracetamol 1 gram, 8 hourly.
Yes.
And sir, before extubation, we can give tab block bilateral.
Bilateral tab block. So bilateral tab block, bilateral QL blocks.
Pardon, sir? QL block also can be given, sir.
So which block you are comfortable?
So tab block.
Tab block. So what is the duration of analgesia with tab block?
Around 6 to 8 hours, sir.
Very brief duration.
Mm.
Okay. So you can repeat it, but the tab block duration, the tab block, bilateral tab block sometimes can cause last also. You have to be careful about
Yes,
it.
sir.
Same thing, they're high volume blocks, okay?
Yeah.
You need to keep in mind the level of local anesthetic, the dose of local anesthetics. So what approach you give tab block?
The USG guided.
Subcostal or
No, not subcostal, sir. Between the ASIS and
Yeah.
in the in the lateral, at
Lateral
the
band.
angle of petit.
Okay. And what else you can give?
Sir, if we cannot give NSAID, so we can give PCA pump can be started, sir, with fentanyl.
Yeah. And anything else you want to give?
Uh,
LMWH prophylaxis
yes, sir.
with 58,000 platelets,
So 58,000,
with 72,000 platelets.
no, sir. Then we won't.
So what prophylaxis you want to give?
We can give DVT, means we can give SAD pump and we can mobilize the patient.
Mobilize SCD pumps. But if the platelet count is more than 1 lakh, start LMWH also.
Then we can start, sir.
So you need to keep this in mind. So automatically NPO, fluid, antibiotic, analgesics, LMWH, SCD, that has to come serially without hesitation.
Yes, sir.
Now coming to most important investigation or most important part of post-op instruction.
Sir, a patient can still have seizures, means postpartum till. So
Yeah,
we should.
what else you want to write in the post-op instructions?
Vital monitoring, output monitoring, sir.
Vital
Because
monitoring,
natural toxicity,
that is standard thing. No? That is a standard thing.
natural toxicity to be checked, sir.
Huh?
Magnesium sulfate toxicity to be checked, sir.
Yeah. See, I'll tell you one thing. Post-op instructions also includes what investigations you want to send and what
Yes.
frequency.
Yeah.
Because I said postpartum HELLP syndrome can occur. Okay.
Yes, sir.
Postpartum worsening of preeclampsia can occur. Isn't it?
Yes, sir.
Now, this patient, she's on magnesium sulfate therapy. She throws a fit.
Yes.
Throws a seizure. How do you manage? Post-operatively.
Sir, we can increase the dose of magnesium sulfate loading dose to 4 to 6 grams. And till it is recurrent, then, sir, we can go ahead with the Levipil, sir.
So we can go ahead now. How do you manage this patient? You have given loading 2 grams.
Yeah.
With 1 gram per hour infusion.
Yeah.
She had GA, recovered from GA because of HELLP syndrome. You gave GA to her. And now, after 6 hours later, she has thrown one more seizure.
So, sir, I'll oxygenate the patient. I'll put a airway so that she doesn't bite the tongue. Then I'll give injection midazolam 2 milligram IV stat. Once the seizure is gone, I'll assess again, and we can do CT brain, sir, to find out the cause.
So basically, medical management and optimization is what is important.
Yes,
so
sir.
you want to give midazolam or you want to give magnesium sulfate?
So at that time, I'll give injection midazolam 2 milligram IV. Magnesium sulfate is already going on.
So basically, when the patient is having a fit while on magnesium sulfate, it is prudent that you avoid polypharmacy.
Okay.
So go for magnesium sulfate repeat dose. You can go give a loading dose of another 2 grams.
Okay, sir.
If the patient is less than 70 kilos, if the patient is more than 70, you can go for 4 grams loading dose.
Yes.
Provided you will not put level of consciousness, rate, and sensorium are okay.
Yes, sir.
Okay. And also send for, before you give loading dose, send for serum magnesium levels also, so that you know whether the therapeutic range is achieved or not.
Yes.
Okay. And then this patient, tonic including seizure is controlled. She's still confused and little obtunded. What do you do?
Then she could be having cerebral edema, sir. We will get one MRI done, CT brain done.
See, before you go for CT scan brain, what do you want to do assessment, head-to-toe examination?
Yes, sir. The patellar reflex, actually.
What do you want to look at head-to-toe examination? As an undergraduate, How do you examine central nervous CNS?
Sir, I'll see whether patient is conscious oriented.
Conscious
Now,
oriented to
yeah,
time, space,
time, place, and person,
person,
and irritable or no.
irritable or
Then I'll check all the reflexes.
higher intellectual functions.
Yeah.
Yeah.
And cranial functions, sir. Higher
Yeah.
cranial functions.
Cranial nerves.
Yeah.
And then
Pupils. Yeah.
Cranial nerves and pupils.
Pupils.
Yeah. So pupils means no, there is anisocoria.
Okay.
So did you check the pupils before induction?
No, sir.
No. So one of the thing that is very important, I think I discussed last time also, develop a habit of checking pupils before you induce the patient.
Okay, sir.
And every 15 minutes under anesthesia.
Yes, sir.
And before extubation.
Yeah.
And suppose if there is any change in size during surgery, do not extubate this patient.
Yeah.
Plan for radio investigation.
Yes, sir.
Okay, because pupils have changed and there is intra-operative or intra-surgical cranial event.
Okay, sir.
So this is a part of consenting process.
Yeah.
You may have to take.
Yes, sir.
For IC bleeds, and this you may require this investigation, this workup.
Yes.
Either after surgery, immediate after surgery, or so that patients are well aware. Otherwise, they think anesthesia complication ho gaya.
Yeah.
Okay. And very, very importantly, whenever we are giving GA to these patients, preeclampsia or hypertensive patients, control of laryngosympathetic response at induction and extubation is very, very important.
Yes, sir.
Do not allow pressures to shoot up like 200, 110 at intubation or extubation.
Yes, sir.
So, blunting of response. I said Loxicard you have given rightly, but suppose it's a preterm fetus, I would refrain from using Loxicard because there is something known as iron trapping.
Yes, sir.
Okay.
Yeah.
Are you aware of that?
Yes, sir.
So we don't give Loxicard in a preterm, premature or fetal distress patient because we don't want to increase fetal distress. So you can go for fentanyl, you can go for magnesium sulfate therapy as a
small also.
Hunting 1 mg, 2 mg per kg again. I mean 1 to 2 grams at induction. Fentanyl, labetalol, NTG, all can be used to blunt the laryngosympathetic response.
Yes, sir.
Intubation and extubation. And you have to mention that.
Yes, sir.
In your notes. Laryngosympathetic response blunted using fentanyl, NTG, fentanyl, labetalol, max self continued, and pressures post-intubation immediately was 140/90. At extubation, pressures were so much. That specifically you have to mention. You got my point?
Yes, sir.
And pupils reacting to light normal in size before induction, intraoperative, and post-extubation also pupils normal in size.
Yes, sir.
Very, very important. Okay, that is very important. And if you are doing BIS monitoring, fine. You need to do an NMT monitoring also in this case because patients magnesium sulfate therapy.
Yes.
Junction monitoring so that you can appropriately reverse the patient. Okay. So now that patient has become obtunded, you do a thorough assessment, neurological assessment, head-to-toe examination. Is it a post-ictal confusion or any CNS event? Suppose if head-to-toe examination is absolutely normal, you can wait for half an hour.
Yes, sir.
Otherwise, you get a normal CT scan. And everything will be fine. You feel everything is fine, which may not be there. Okay. So wait appropriate for movement to do a clinical assessment, and then once the patient stabilizes, you want to go for CT scan or you want to go for MRI? Obtunded patient. Patient is still obtunded, but arousable, but drowsy. So if you are giving magnesium sulfate therapy,
yes, sir.
Midazolam therapy, you don't know whether midazolam is causing drowsiness or CNS pathology. So there's the reason you should not give benzodiazepines.
Okay.
Or refrain unless you know what it is. Okay.
Yes, sir.
So CT or MRI? Divya says CT. See, if the patient is hemodynamically stable, breathing comfortably on her own, then I would go for MRI of the brain with MR venogram.
Yes, sir.
If the patient is unstable, drowsy, then quick in, quick out. CT scan, plain CT scan is enough. But a normal plain CT scan does not mean that patient is not having any intracranial problem. A CT scan will rule out only bleeds, IC bleeds. But CT scan will not rule out press syndrome. A CT scan will not rule out deep cerebral sinus venous thrombosis.
Yes, sir.
Okay.
Yeah.
So for that, again, you may have to subject her to MRI with MR venogram.
Yes, sir.
So a quick CT, yes, if the patient is hemodynamically stable, a quick CT is fine. But again, 6 to 12 hours later, you may have to plan for MRI with MR venogram.
Yes, sir.
Okay.
Yeah.
Now this patient has had a repeat seizure. Everything is fine. You could control with magnesium sulfate therapy. The patient recovered, did not have any sort of obtundation. Pupils were normal. You shift the patient to ward.
Yes, sir.
Preeclampsia profile, that repeat profile also was relatively normalizing.
Yes, sir.
On the second day, she develops tachycardia and tachypnea. You get a call again.
Yes, sir.
Are you worried? BP is 150/90.
Yes, sir. Patient. He could be developing pulmonary edema, sir.
Pulmonary edema, yes. What else? See, Dr. Azam has given Mississippi classification, class 1, class 2, class 3. Just you can note it. And you have the CBIS classification also. You
Yes,
just
sir.
Google search it, okay? So now this patient has respiratory distress, tachypnea, tachycardia. Pulmonary edema, possibility.
Embolism, sir.
How do you rule out pulmonary edema? Embolism is there, pulmonary edema is there, yes. Heart
Pulmonary,
failure.
we can
Why, you see, you start developing using ultrasound, boss. Ultrasound,
sir.
ultrasound, B lines, A lines, B lines, C lines.
Yes, sir.
So you are not seeing any B lines, but you see C lines. What does it mean? You are seeing C lines or C lines in right lower zone.
So it is pulmonary edema there.
Pulmonary edema में B lines दिखते हैं ना बेटा. Are you able to listen to me?
Yes, sir. Listen.
See, she has aspirated following second seizure.
Okay.
You got my point?
Yes, sir.
So whenever you have this patient's this thing, don't take things for granted. Always follow up this patient. So whenever the patient throws a generalized tonic and clonic seizure, the risk of aspiration is always there.
Okay.
So watch proactively for that.
Yes, sir.
And other thing which I said is she was having obtundation, CNS obtundation was there following seizure. So anything else could have done for rapid assessment? ONSD assessment.
Okay, sir.
Optic nerve sheath diameter.
Yeah.
So embrace this technology of using ultrasound. I know we are a little shy on using these newer gadgets and newer technology, but believe me, ultrasound is a very useful device. So optic nerve sheath diameter assessment, and then B lines assessment, volume assessment, Suppose if the patient develops sudden hypovolemia post-operatively, or hypotension post-operatively, or oliguria post-operatively, do a quick e-fast.
Okay, sir.
Is it bleeding intraoperatively? Hemoperitoneum kuch hai kya?
Yes, sir.
So all these things you can assess. So develop this skills of using ultrasound routinely. Okay.
Yeah.
Yeah. Just to quickly summarize, hypertensive parturient, we have looked at classification of hypertensive disorders.
Yeah.
We have looked at placing the patient in right basket, which
Yes, sir.
category they belong to, and importantly, classification and the entire spectrum. Then hypertensive crisis, urgency, emergency, pulmonary edema, eclampsia, recurrent eclampsia, then postpartum eclampsia, then importantly, you have had HELP syndrome, the partial or incomplete HELP syndrome or complete HELP syndrome. You have Mississippi classification, you have CBIS classification. Look into both the categories, and correction of coagulopathy before surgery, and intraoperative management, the cause of metal mortality. And we didn't go into the details of HELP syndrome, but just to summarize, what are the mix of HELP syndrome? Mimics. What are the different diagnoses of HELP syndrome?
You're muted, Reena. You're muted.
What are the differential diagnoses of HELP syndrome?
Yes, sir. Sir, it could be hemolytic uremic syndrome.
Yes,
And
yes, very good.
then thrombotic thrombocytopenic purpura.
Excellent.
Then antiphospholipid antibody syndrome.
APLA syndrome, yes. Yes, you're right. Sepsis.
Yes, sir.
Sepsis, AFLP, HUS, TTP. So how do you differentiate quickly? In our country, tropical diseases like dengue, malaria, hepatitis
Yes,
A, hepatitis E. See, you have jaundice, you have hemolysis.
Yes, sir.
Sickle cell disease, you have jaundice, you have hemolysis.
Hemolysis.
Malaria, you have jaundice, you have got hemolysis. Okay?
Yeah.
Hep A, Hep E, jaundice, hemolysis.
Yes, sir.
Leptospira, jaundice, hemolysis.
Hemolysis.
Strep typhus, jaundice, hemolysis.
Yes, sir.
So, in our country, you need to look into all these differential diagnosis, because if it is malaria, scrub typhus, leptospirosis, easily treatable causes.
Yes, sir.
You don't have to terminate the pregnancy. Hepatitis A, hepatitis E, same presentation, you don't have to terminate the pregnancy.
Yes, sir.
Okay?
Yeah.
HELP, AFLP, terminate the pregnancy.
Yeah.
HUS, you don't have to terminate, but
Um,
again, it's very different. It's a fine line whether it's HUS. How do you quickly diagnose what is HUS, what is TTP, what is... it is too much, right? So that is the homework for you.
Yes, sir.
How do you differentiate HUS from HELP? How do you differentiate TTP, HUS from HELP? Basically, HUS, as you rightly said, hemolytic uremic syndrome. Predominant involvement is kidney,
Kidney, sir.
less of liver.
Okay.
But LDH is in thousands.
Okay.
Okay?
Yeah.
Sepsis, lactate is elevated.
Yes, sir.
Cultures are positive. AFLP, predominantly liver involvement is there. But again, HELP, AFLP is part of hypertensive spectrum only.
Okay.
Management is same. Treatment is termination of pregnancy.
Yes, sir.
But pancreatitis involvement is more common in AFLP.
AFLP.
Okay. So you need to know these differentials so that you can manage appropriately. Hypoglycemia, the Swansea criteria of AFLP, you need to remember that. Okay.
Yeah.
Yeah. So just that is the homework for you.
Yes,
There
sir.
is something known as ADAMTS essay, ADAMTS 13 essay.
Okay.
Are you aware about that investigation?
No, sir.
Just look into that.
Okay.
Again, that's a little higher discussion, but just have to, as you evolve yourself, you can go into those level of management also. Okay.
Yes, sir.
So, anything else you want to know? So, management of eclampsia, you have to be thorough. Management of HELP syndrome, management of preeclampsia with severe features, pulmonary edema, and complications. Okay.
Yes, sir.
So, Press syndrome, we have not discussed much, but Press syndrome, why Press syndrome? How do you manage Press syndrome?
So it's posterior reversible encephalopathy syndrome. It's reversible, sir. And patient will
What is the basic
be
pathology?
irritable.
What is the basic pathology?
Sir, cerebral edema is there. The parietal and the occipital lobe is involved, sir.
Yeah. So basically, Press entity, is it a new entity or the old entity?
So it's a new entity.
Press is as old as preeclampsia.
Okay.
It has become a new entity in 1980s because the MRI has developed then. So it's a
Okay, sir.
basically any parturient with preeclampsia with blurring of vision. Headache, blurring of vision, you do MRI, you
Yes,
see
sir.
Press. So basically, Press is nothing but a breach in blood-brain barrier in the presence of low oncotic pressure. If you look at the basic pathophysiology, the oncotic pressures in pregnancy are low.
Yes, sir.
Because serum albumin is low.
No.
And in that, when the hydrostatic pressure is high, that is the systemic blood pressure is high, the SVR is high, there is a breach in blood-brain barrier which leads to vasogenic edema
Yes, sir.
of the neuronal cells, which causes blurring of vision. And if you don't treat this blood pressure properly, you go in for cytotoxic edema,
Yes,
which
sir.
results in infarcts, acute multiple small vessel infarcts, from which the patient can have a delayed recovery of neuronal injury. So Press syndrome has to be treated as medical emergency because I don't want my Press syndrome, which is the initial vasogenic edema, to go into cytotoxic edema. Are you getting me?
Yes, sir.
So the best way to control is we cannot control colloid oncotic pressure because that is a pregnancy-induced change.
Yes,
What
sir.
we can control is systolic blood pressure.
Yes, sir.
So maintenance of blood pressure is very important. So Press syndrome, is it specific to pregnancy only? So any condition, medical condition that can cause low oncotic pressure with high blood pressure can cause Press syndrome. Like classic is transplant patients,
Yes, sir.
renal transplant, liver transplant, nephrotic syndromes, low oncotic pressure because of excessive proteinuria, CLD, the liver is not able to synthesize more protein, so low oncotic pressure. And when the hydrostatic pressure increases, you can cause Press syndrome. So you can see Press syndrome in CKD patients with like transplant patients. You can see in liver CLD patients. You see in pregnant patients.
Okay, sir.
Okay. So just have to keep in mind. So basically low oncotic pressure and breach in blood-brain barrier.
Yes, sir.
So control of blood pressure is very important. Okay.
Yes, sir.
So even a patient with severe preeclampsia or preeclampsia with severe features and imminent signs like blurring of vision, you get a MRI done, you'll see Press syndrome.
Okay.
Like a typical T2 flare imaging, T2 weighted flare imaging, fluid attenuated imaging on MRI. Okay.
Yeah.
So because advent of MRI took place in 1980s, this diagnosis is recently coined term. Otherwise, it's been there since ages, since the time the hypertension spectrum has been described, 18th century. Okay.
Yes, sir.
So we have discussed almost all the entities of hypertensive spectrum, and probably this was a very milder case present. I mean, which you have had, but you can see more fulminant cases. Just Dr. Azam, are you still there?
I
saw
think I
Azam.
think he's yet there. So he just sent me a message.
Yeah.
He's there. He's there.
Dr. Azam, can you unmute? He's an excellent teacher as well.
Yes.
He just managed one fulminant case of AFLP 3 days back, and Ketan managed fulminant help 2 days back at Bridge Candy. Just I think the patient must still be there in hospital. You can just have a
What?
look through. You can just discuss with Ketan whether you can. It's a very, very good case actually.
Hi, good afternoon, sir.
Hi Azam. Lovely to
Superb,
have
sir. Superb discussion.
you.
Every time you discuss, maybe I must have heard fifth or sixth time. Every time I've attended your lecture. Excellent. It's
You can
so.
add few points.
No, sir. I think you've covered. I mean, everything you've covered. I mean, thanks to Dr. Kalpana to getting you on the board.
I must thank him, Dr. Azam. In spite of his busy schedule, he's always
Seriously.
ready to teach. That just shows the teacher in him, which is always ready to impart knowledge.
Seriously. Thank you, sir. Fantastic, sir. Anyway, that patient, sir, the AFLP patient to
I
update
think you
also.
can, because this is a related case, you can discuss. Reena is a very good case that Azam has managed just 3 days back.
Okay, sir.
You can
She,
just discuss about that case, how they
yes, sir.
presented. Yeah.
She was referred from some other place with bilirubin of 18, INRs of about 7 gram, I mean 7, and hemoglobin about 9.8. And when she came in about 12 o'clock in the night, and she was posted for next day. So when we got a call, that is at morning 6 o'clock, then we rushed in to see her. Her SGOT, SGPTs were all haywire, ALP, alkaline phosphatase, everything was totally messed. Her APTT was about, I think, 78 was her APTT. And she was fully jaundiced. And we tried to, then I had to call up Sunil sir, actually, in fact, to get some hints from him how we could manage. So sir gave us a few tips of, to arrange, at least to get the INR at least to 2. Luckily, but we gave about, I think we gave about 12 cryos, FFPs, and luckily we got the INR to about 2.08, if I'm not wrong. Then her urinary output had already started getting, reduced. So her creatinine, which was about 1.3, rose to 1.9. Then we were, so 2.08 was okay. We didn't want it to bring it down to normal again. So we took her for section. Luckily, she did not bleed much. We had about, I think, 2.8 to 3 liters of blood loss. Somehow, interop again, we gave her the remaining 10 cryos. Sir, in fact, we gave her FDP, or fibrinogen, sir.
Yeah, that's very important. Like we didn't discuss
we
it.
gave In fact, her fibrinogen level came as I think 142 or something like that. It was too low. It was quite low.
So Reena, one of the things that is important is whenever you have a fulminant DIC, instead of going for cryos and FFPs, which see the thawing time for FFP is 25 minutes.
Yes, sir.
If you want to give 6 or 7 FFPs, like you said, 15 ml per kg,
Yeah.
and if the fibrinogen also is low, better to go for 3 grams of fibrinogen straight away IV.
Okay, sir.
It's available as a lyophilized powder, diluted.
Okay.
One vial is 1 gram. The only thing is it costs about 12,000 rupees,
Okay.
1 gram. But it is worth it because you can minimize blood loss and you can rapidly correct coagulopathy.
Okay, sir.
Because once
So-
you raise the fibrinogen to more than 250 with 220 milligrams per deciliter, you can minimize blood loss. So you can absolute risk of transfusion, absolute number of units of transfusion also reduces.
Yes, sir.
True. So she required total of about 6 PRBCs, sir. But problem is her this thing came out to be microangiopathic hemolytic anemia with the cystocytes, with burst cells and broken RBCs. So she died. Sir, I wanted to ask you one thing. What is the role of plasmapheresis, which we are doing now?
Yeah. Plasmapheresis versus that's what exactly I was talking to Reena. How do you differentiate between these 4 entities? So AFLP versus HUS versus TTP versus sepsis versus other entities like HAS, so like hepatitis A or E. So plasmapheresis is indicated when you're suspecting TTP and HUS. TTP is very rare actually. HUS, the hallmark of HUS is LDH is in thousands, like 3,000, 4,000, 5,000. That is one of the things, and predominantly urinary involvement.
Hmm.
So in this case, with bilirubin of 18, HUS, you will never see bilirubin of 18.
True, sir.
Unless HUS with sepsis, fulminant sepsis causing liver dysfunction or liver failure. So whether you want to do HUS plasmapheresis or not, one investigation is ADAMTS13. I was just telling Rina to work on that, look for that. So ADAMTS13 assay is ADAMTS virtual low levels or absent levels of ADAMTS13 points towards HUS.
Yeah.
So then you can subject the patient for plasmapheresis.
There is no point, no, sir.
Otherwise, there is no need.
LP per se as such.
Regular dialysis, current dialysis should suffice. So
She's on dialysis
LDH clinically, LDH levels and ADAMTS13 if you don't have, but ADAMTS13 is available in most of the country. I mean, most of the cities now, I would say. At least in our hospital, we do it. The only thing is it's a little expensive, about 8,000 or 9,000, this thing, one test. But it will differentiate, it will clinch your diagnosis. You're dealing with HUS or AFLP or TTP. So TTP and HUS, the ADAMTS levels are almost absent. Whereas HELP it is reduced and AFLP is almost near normal or mildly reduced.
I think in
Another thing is LChat levels, like if
LChat is awaited, sir. Yeah.
Yeah. So that is other thing that you can clinch. But
Fantastic, sir. I thoroughly enjoyed your
Your patient you'd manage with point of care thromboelastogram or a sonoplot?
no, we don't have TEG. We do
Yes.
not have TEG.
again,
Yeah,
tag I would say is not mandatory, madam.
absolutely.
Clinical inference is good. If you have point of care tag, nothing like it, you can give definitely targeted therapy, because now you have rapid tag also, where you can within 15 minutes you can get the trend and you can target the therapy. But importantly, if you look at the spectrum of availability of tag across the country, it is still probably less than 100 centers in the country who have tag, and 80 to 90% of obstetrics happen in non-tech centers. And the corporate hospitals that have tech hardly do any obstetrics.
Sir,
So,
if I'm not wrong, I think there was once, studies that had come out that where they compared tech versus regular. So they did not find much, as you say, the
so
availability itself
clinical inference is very important. Thumb rule way of management is very important. Yes, sometimes. So what we do is the thumb rule assessment and management of coagulopathy with 15 ml of per kg of FFP, 10 ml per kg of cryo. I mean, 1 unit of cryo for 10 kgs. Most of the time suffices. But yes, what we have seen now that when you have tech, you can reduce the absolute requirement of transfusion by about 15 to 20% when you go targeted therapy. So definitely it's useful, but if it is not there, no regrets. You can
Yeah.
always go for clinical assessment and management.
Too expensive equipment, sir. About 27 lakhs or something like that.
But more importantly, equipment is expensive, but maintenance part also is should be there. So you need to have a technician, or it has to be in the theater. When you have multiple users handling tech, again it gets spoiled in no time. We had our center was the classic example. So now we have a dedicated technician who gives you the report, and the technician is there only for 12 hours. So remaining 12 hours, he's not there. So night time में कुछ tech होना तो हमारे पास भी नहीं होता है वो. So daytime, yes, from 8 a.m. to 8 p.m. it's available. So now, of course, we have put a requirement for 24/7, but so there are certain restrictions. But point of care, अगर नहीं है तो भी serum में you just take 5 ml of blood in a plain serum lead drop container and leave it for about 15 minutes or 10 minutes and then see the status of it, liquid status, or is become solidification. That also is a crude method, but this was a study that came from AIMS Raipur that you're talking about, Azam.
Yes,
AIMS,
sir.
they had compared tech with this technique, and they felt that more or less it's correlating. But again, that was a very observational study, so not many cases were done. But in a country like ours, LMS is having tech is a luxury, at least in most of the centers. But if available, then go for it. Go for it. But embrace this ultrasound. Called,
Yes.
especially ONSD, a very short learning curve for ONSD. Just you do 5 cases, you know how to assess optic nerve sheath diameter. For EFAST and thoracic echo, you need to have certain short learning curve. But for ONSD and volume assessment, a very short learning curve. And if you do go on doing regularly, it becomes a routine thing.
In fact, for this AFLP patient, soon after extubation, I expected her on table, sir. Luckily, because I didn't wanted her to bleed anywhere else. Ultrasound, I mean, post-op, immediate post-op, her saturations are 92, 93. So just put an ultrasound and see on the chest, she had curly B lines, many curly B lines. So started her Lasix infusion, I mean, furosemide, and she came out of it. But luckily, I mean, bad luck that she's gone into renal shutdown.
But see, that is inevitable. So we need to, when you are taking a consent, no, Reena, I told you about RRT. It's very important. Ventilation, RRT, radio imaging,
Yes.
radio imaging immediately after surgery. All these possibilities, if you are discussed, if they are well informed, no, the patient attendants are also aware. अरे हाँ इसके लिए बोला था मुझे पहले ही बोला था पहले बताया गया था नहीं तो suddenly they think that something has happened. पहले कुछ हुआ नहीं आपसे कुछ गड़बड़ हो गया उसी में कोई बोल देगा BP was very high at the during surgery and you are in soup. So you need to inform the patient and this thing. And quickly, we didn't discuss much on regional anesthesia.
Yes, sir.
Suppose if you have to do neuraxial imaging in this patient which you have presented, how do you do neuraxial imaging?
So we see for the USG, we see for the spikes.
I'll ask you only one question. Any specific precaution you want to check when you are assessing the depth in this patient?
Our patient will be having, sir, edema in that space. So, due to the venous engorgement and due to the edema, the space, epidural space is.
So when you're assessing the depth of SC, basically you're assessing the best interspace.
Yes, sir.
You're assessing the depth of posterior spinal complex, right?
Yes, sir.
So any specific precaution you want to take when you're doing ultrasound imaging, neuraxial imaging? So that you don't puncture the dura. You don't exert too much of pressure.
Okay, sir.
See, just hold the probe lightly.
Okay.
If you're pressing too much, you're displacing the fluid and you're trying to reduce the distance.
Yes, sir.
You're getting me?
Yeah.
So sometimes the patient's back is so boggy that if you're putting a firm pressure on the curvilinear probe which you're using,
Yes, sir.
you may displace the fluid and then you may get a false, the space may come down by at least 4 to 5 millimeters. And subsequently you end up, depth of 5 centimeter pe aaya mujhe, and
Yes,
you
sir.
end up doing a dural puncture.
Yeah.
So
Okay.
apply jelly liberally and put the probe lightly without pressing the skin too much.
Yes, sir. Okay, sir.
That is very important. Okay. Yeah.
So do you do all neuroactions with ultrasound guided?
No, sir. No, madam. We don't do as a routine, but only a few cases where we feel, yes, back is pathological. But we do have ultrasound in the theater, so that low threshold.
Sir, I think you should come more often because it helps really the postgraduates to, think otherwise. See, the best thing what I liked was one is the targeted PAC.
Yeah.
No point in going, I mean, yes, exam point of view, yes, but when you're a clinician, you would like to, I mean, in process of taking the history, you will miss out the main important points, which should, I think, excellent, sir. Lovely talk. Enjoyed thoroughly.
Okay, so have a great New Year celebration, each one of you.
Yes. And I must thank you, Dr. Pandya. This year you've come the second time for our students. And it's really been so helpful. In fact, when I told Reena that you would be coming, she was so tensed. She said, because last time, if I remember, Shweta was there and we had a nice session that time as well. And she was very tensed about it. I said, just relax, don't worry. And it was kind of you to come even an hour early. And we did have a mock trial as well. So I think that's really helped her.
Last time I was in Puri.
Yes, sir. Yes, you were.
I had gone for pre-wedding shopping. Now it's post-wedding relaxation, I would say.
In fact, sir has been one of the most humble examiners.
Exactly.
I must.
Dr. Pandya, any word you would like to give of to our postgraduate students, because there are 4 of them who are going to go in for their practicals now, and the rest of them are going to, of course, meet you next year again. But any word and anything about Reena, where she should study more, or how should she present more? Please do.
Basically, what we discussed little on the higher side, beyond routine PG, but importantly, you study hard. There is no second thought about it. See, you need to read a lot, and reading doesn't suffice alone. So reading with the clinical management also is very important. So if you read something and then you see the patient and you manage the patient as per what you have read and as per the evidence, it remains in your brain for longer time. If you read a lot and you don't manage clinically, then it may not stay for long. So reading is very important, and at the same time, clinical management anesthesia is very, very important. So like when you're pre-oxygenating a patient, peri-oxygenate the patient and start doing it. So that becomes a culture. So automatically, you know that, yes, I need to give CPAP to this patient. I need to give HFNC to this patient. I need to give nasal cannula. It becomes a routine culture and becomes easy for you. So read a lot. Yes, there is no second thought on it. And when you read the entity, you always, as Azam said, the targeted PAC will come only when you know what to target. So eyes cannot see what mind does not know. So you need to make sure that your mind knows and eyes sees. Otherwise, you may be seeing a patient, but you don't know anything about that entity. Like suppose if I'm giving an epidural and suddenly it has become Horner syndrome, unless I know that it's subdural can happen and I need to look for Horners, and Horners may, ophthalmos, ptosis, or anhydrosis, and Gutman sign, all these things are possibility. And if you know and if you target it, you recognize it. Otherwise, our colleagues sometimes they don't recognize subdurals also. So you need to know about the procedures, the complications which are likely to occur with that procedure or with that disease per se. Then automatically your management becomes, everything will be in place. So like when the patient, as I said, when the patient becomes obtunded, you said, I'll do a CT scan. But before that, basic clinical examination, stabilization, ABCs, the basic things. So exam may always that clinical assessment and clinical management is very important rather than investigations. So stabilization of patient, assessment of patient, and once stabilized, then you subject the patient for further investigation. Or if the patient is hemodynamically unstable, then assessment, stabilization, evaluation has to go hand in hand. So those things will come with experience, but importantly, read a lot and manage as many cases as possible. Don't leave out any patients with any interesting case in the hospital, even if it belongs to other unit or the consultant. Harp on them and see that you see that patient, follow up the patient. As I said, start writing post-op instructions because that is your domain. And make surgeons dependent on you. That is very important.
Yes.
Yeah. So we know we are weaker in areas of, if you see post-op management is NPO, fluids, analgesia, and antibiotics, and previous medications. What else? And who else can write better pain medications and fluid therapy? We just have to know about more of antibiotics. And if you start reading about antibiotic therapy, what, when, and you can soon overcome, because surgeons are so busy now with their surgical related things, you take, or they'll be very happy to give all to you. But provided you take enough on your shoulders and then do justice. And importantly, in front of patients also, your status will go up. Okay, this person also is equally important in the perioperative period. Otherwise, you'll be just coming in at one point and then going off. That's it.
So well put, Dr. Pandya, really well put. So I think I'd thank you so much, sir, once again to be with us. And thank you, Reena, for all your efforts. In fact, she was
Thank you, ma'am. Thank you, sir.
behind me because we got delayed for a few days. Thank you, Dr. Azam, also for joining us. We have some of our senior madams from Bombay, Dr. Daigode Madam, Naik Madam. I must thank all of them for joining us on this Sunday morning and encouraging our students. And sir, I wish to see you more on this platform.
Yes, madam. Thank you.
you so much, sir. Thank you so much. And all of you all have a great year ahead. So let's
Yeah.
meet.
Yeah,
Thank
it
you,
was
madam, and wish you all a
fantastic.
happy new year.
Excellent.
Thank you, sir.
Great.
Thank
Happy
you
New
very much
Year.
for all the help. Thank you.
Happy New Year to everyone.
Thank you. Thank you. Bye-bye, ma'am.